Berkibarlah bendera negeriku, berkibarlah engkau di dadaku, tunjukkanlah kepada dunia semangatmu yang panas membara. Daku ingin jiwa raga ini selaraskan keanggunan. Daku ingin jemariku ini menuliskan karismamu. Berkibarlah bendera negeriku, berkibar di luas nuansamu, tunjukkanlah kepada dunia ramah tamah budi bahasamu. Daku ingin kepal tangan ini menunaikan kewajiban putra bangsa yang mengemban cita hidup dalam kesatuan. Daku ingin jiwa raga ini selaraskan keanggunan. Daku ingin jemariku ini menuliskan karismamu. Daku ingin kepal tangan ini menunaikan kewajiban putra bangsa yang mengemban cita hidup dalam kesatuan Indonesia.
Selamat datang di Fakultas Kedokteran dan Ilmu Kesehatan Universitas Warmadewa. Fakultas Kedokteran dan Ilmu Kesehatan Universitas Warmadewa merupakan fakultas termuda yang dimiliki oleh Universitas Warmadewa, bernaung di bawah Yayasan Kesejahteraan Korpri Provinsi Bali sebagai badan hukum penyelenggara perguruan tinggi swasta. Fakultas Kedokteran dan Ilmu Kesehatan Universitas Warmadewa berdiri pada tahun 2009 dengan mengantongi izin dari Dirjen Dikti tahun 2009. Fakultas Kedokteran dan Ilmu Kesehatan Universitas Warmadewa memiliki 4 gedung yang terdiri dari gedung F1, F2, F3, gedung E, serta fasilitas penunjang seperti lapangan basket, lapangan voli, tempat ibadah, kantin, serta parkir yang luas. Gedung F1 merupakan gedung pertama yang dimiliki oleh Fakultas Kedokteran dan Ilmu Kesehatan Universitas Warmadewa di tahun pertamanya berdiri. Dengan fasilitas yang belum memadai dan personil yang minim, tidak menyurutkan semangat kami dalam memberikan pelayanan yang terbaik. Dan FKIK Unwar membuktikan pada tahun 2010, FKIK Unwar mendapatkan kepercayaan dari Kemenristek-Dikti dalam memenangkan hibah PHK PKPD. Pada tahun 2011, gedung F1 mulai direnovasi dan dimanfaatkan sebagai ruang anatomi histologi, ruang bagian biokimia fisiologi, ruang farmakologi, ruang parasitologi, ruang IKK-IKP, serta ruang subtropik yaitu ruang Medical Education Unit. Mendatang, ruangan ini akan menjadi ruang baca yang memiliki fasilitas yang sangat baik. Lantai 2 gedung F1 terdapat ruang administrasi skill, ruang bagian parasitologi dan mikrobiologi, ruang unit bioetik, ruang kerjasama dan ruang rapat. Di lantai 3 terdapat ruang bagian IKK-IKP, ruang kuliah semester 7 dan tentunya difasilitasi dengan toilet. Selanjutnya, gedung yang dimiliki oleh FKIK Unwar adalah gedung F2. Gedung ini merupakan gedung yang baru diresmikan pada tahun 2011. Gedung F2 dilengkapi tangga dan lift untuk menuju ke setiap lantai. Lobi gedung F2 terletak di lantai 1 yang juga terdapat pos satpam, ruang baca, dan ruang BEM. Lantai 2 terdapat lobi, ruang dekan, ruang sidang besar, ruang sidang kecil, ruang server, akses menuju ruang CBT Center, ruang tata usaha yang di dalamnya terdapat ruang wakil dekan 1, wakil dekan 2, wakil dekan 3, ruang kepala tata usaha, dan subbagian penunjang proses pembelajaran, serta ruang IT dan AFA. Saat ini lantai 3 dimanfaatkan sebagai ruang prodi akademik, ruang ketua prodi profesi, ruang unit UPMF, ruang konseling, ruang UP2M, ruang unit MEU, ruang WMJ, akses menuju ruang diskusi, serta toilet. Lantai 4 terdapat CBT Center yang dimanfaatkan untuk ujian blok dan ujian CBT UKM PPD dengan 240 workstation, dua buah server utama dan server cadangan yang ditenagai prosesor Intel Xeon dan OS Windows Server 2008. Fakultas Kedokteran dan Ilmu Kesehatan Universitas Warmadewa juga memiliki gedung E yang dimanfaatkan sebagai ruang lab anatomi, ruang kepala lab anatomi yang terletak di lantai 1. Pada lantai 2, dalam pengembangannya, gedung E dimanfaatkan untuk ruang dosen anatomi, ruang dosen patologi, ruang dosen histologi, ruang dosen fisiologi, ruang dosen biokimia, ruang dosen farmako, lab animal breeding, ruang administrasi animal breeding. Fakultas Kedokteran dan Ilmu Kesehatan Universitas Warmadewa pada tahun 2020 meresmikan gedung F3 yang pada lantai 1 terdapat lab terpadu yang terdiri dari lab biomedik, lab penelitian, lab biomol yang saat ini ditunjuk oleh pemerintah Provinsi Bali dalam penanggulangan COVID-19 di Provinsi Bali. Selain itu juga, FKIK Unduar memiliki laboratorium biomedik, laboratorium kesehatan masyarakat, dan laboratorium unggulan yaitu kesehatan pariwisata. Di lantai 2 terdapat ruang skill lab yang terdiri dari 28 ruang OSCE Center yang memiliki fasilitas sangat baik dari segi fasilitas dan internet yang dilengkapi dengan 4 ruang penguji, loker sebanyak 324, ruang pasien, ruang laboran, ruang manekin, dan dilengkapi toilet dan akses pintu darurat yang telah memenuhi syarat K3. Pada lantai 3, terdapat ruang SGD sebanyak 40 ruangan dengan fasilitas yang sangat baik, dilengkapi oleh AC, proyektor, papan tulis, meja, dan kursi diskusi. Di lantai 4, terdapat ruang guna pria Dharma Patni Madaka 1, 2, dan 3 yang dimanfaatkan sebagai ruang kuliah dengan fasilitas masing-masing ruangan yaitu 180 orang, terdapat sound system, LCD theater, terdapat loker sebanyak 240, ruang tunggu dosen, dan toilet. Terima kasih. Selamat datang di Fakultas Kedokteran dan Ilmu Kesehatan Universitas Warmadewa. Saat ini, Fakultas Kedokteran dan Ilmu Kesehatan Universitas Warmadewa memiliki satu ruang CBT Center yang terletak di gedung F2 lantai 4 dengan kapasitas dan fasilitas yang sangat baik, yaitu CBT Center memiliki kapasitas 240 workstation dengan 2 pintu masuk yang berdampingan. Dilengkapi dengan 25 jendela, 8 unit AC kaset 5 PK, 27 titik lampu TL, dan 32 titik lampu LED. Workstation dipisahkan oleh sekat setinggi 100 cm. Jarak antara workstation adalah 80 cm. Terdapat CCTV yang dapat dinonaktifkan saat ujian berlangsung, serta 2 buah layar TV pemantau, meja admin, dan sound system. Server utama dan server cadangan dengan spesifikasi yang sama, yaitu HP ProLite ML350G8 dengan prosesor Intel Xeon 2,9 GHz, memori 8 GB, dan HDD 500 GB. Sistem operasi yang terpasang pada server utama adalah Windows Server 2008 R2. Sedangkan pada server cadangan terinstal Windows 7 Ultimate. Semua unit workstation, server, dan perangkat jaringan di-backup dengan UPS sentral yang memiliki kapasitas total 40 kVA 40 ampere hour. Total electricity yang mengalir ke ruang CBT Center sebesar 197 kVA. Dengan backup genset yang berkapasitas 500 kVA dan aktif dalam waktu maksimal 30 detik bila terjadi pemadaman. Akses CBT Center ada 3, yaitu lift yang berada di gedung F2, tangga yang berada di kiri kanan gedung F3. Ruang karantina berada di gedung F3 di belakang gedung F2, yaitu ruang GDM1 dan GDM2 yang masing-masing memiliki kapasitas 180 orang dan sangat memungkinkan apabila dilakukan physical distancing. Ruang karantina memiliki fasilitas ruang kedap suara, pencahayaan dengan lampu LED dan lampu TL, AC cilik, sound system, dan tidak terdapat toilet di dalam ruangan. Loker berjumlah 240 berada di ruang umum dan berfungsi dengan baik. Ruang transit dan musola berada di ruang gedung F3. Toilet terdapat di depan CBT Center dan di bagian selatan gedung F3. Gedung F3 lantai 4 memiliki 2 buah pintu darurat yang berada sebelah kanan dan kiri gedung, dan 2 pintu darurat di dalam CBT Center. Peserta yang baru datang di-screening oleh panitia terlebih dahulu dengan termoglan maksimal 37,5 derajat Celcius. Selanjutnya, peserta diminta mencuci tangan 20 detik, menyerahkan hasil rapid test, dan surat pernyataan. Peserta ujian membuang masker lama dan mengganti masker dengan yang baru. Selanjutnya, 4. Melalui tangga samping gedung F2. Peserta akan meletakkan seluruh barang pada loker, dan peserta akan diarahkan ke ruang karantina di GDM 1. Sebelum ujian berlangsung, mahasiswa dipersilahkan ke toilet. Apabila waktu ujian sudah tiba, peserta ujian dipersilahkan ke CBT Center sesuai nomor urut peserta. Peserta diperiksa dengan metal detektor, pemakaian hand sanitizer, dan duduk di workstation yang telah ditentukan oleh panitia. Setelah ujian selesai, peserta akan kembali ke ruang karantina di GDM 2. Mengganti masker dengan yang baru dan keluar sesuai dengan waktu yang ditentukan. Terima kasih.
Berkibarlah bendera negeriku, berkibarlah engkau di dadaku, tunjukkanlah kepada dunia semangatmu yang panas membara. Daku ingin jiwa raga ini selaraskan keanggunan. Daku ingin jemariku ini menuliskan karismamu. Berkibarlah bendera negeriku, berkibar di luas nuansamu, tunjukkanlah kepada dunia ramah tamah budi bahasamu. Daku ingin kepal tangan ini menunaikan kewajiban
May I have your attention, please? Good morning, ladies and gentlemen. Welcome to the day 2 of Warmadewa International Webinar on Travel Medicine. We would like to thank all participants and our honorable speakers who are willing to attend this webinar. Before we start the webinar today, I would like to read the guidelines of this webinar. Okay, for the first one, please mute your microphone during the webinar. Second one, participant could ask questions via chat in Zoom applications. Please put your full name and institutions followed by your questions. And the third, all questions will be sorted by the committee to be answered by the key speakers in the plenary discussions. Fourth, all participants could also directly ask questions to the key speakers in the discussion sessions by raising hand. And today is the second day of webinar, which will be divided into 4 symposium. So the first session is 4th symposium with topics relaunching medical tourism in Indonesia. The 5th symposium is infection threat at the destinations. The 6th symposium is about traveling in special populations. After the discussion sessions in the 6th symposium, there will be 15 minutes break time before we continue to the 7th symposium with topic cocktail nibbles. Now let's start with the 4th symposium, relaunching medical tourism in Indonesia. This symposium will be led by me, also as the moderator today. First of all, I would like to read my own CV. My name is Dr. Komang Triani Kartinawati, MPH. I was graduated as medical doctor from Pajajaran University Bandung, Indonesia in 2009. And I got training with CMS, Centers for Medicare and Medicaid Services, with a Certified Application Counselor or CAC in the USA 2016. And I was graduated as a Master of Public Health or MPH in the University of Arizona, USA in 2017. My current position is a lecturer at the Department of Public Health, Faculty of Medicine and Health Sciences, Warmadewa University, Bali. I am also the staff at Warmadewa International Affairs at Warmadewa University, Bali, Indonesia. And my research interest is about global health and health promotions. And for today's webinar, the 4th symposium, the key speaker is Dr. Mukti Eka Rahardian, Mars MPH. Now, I would like to introduce Dr. Mukti Eka Rahardian, Mars MPH. I will briefly read the CV of Dr. Mukti. His academic background, first one, graduated as medical doctor from Faculty of Medicine in Unisula, Semarang in 2000. And second one is as the Master of Hospital Administration in the Urindo, Jakarta in 2011, and a double degree with a Master of Public Health with concentrations in policy and management of healthcare in the Faculty of Medicine, Gadjah Mada University, Yogyakarta, Indonesia in 2015. And currently, from 2020, he is also a doctoral candidate in STIA, State Administration Institute in Jakarta. His current position is as a staff in Ministry of Health and the head of Indonesian Health Tourism Medical Association or Persatuan Kedokteran Wisata Indonesia Perketwi. His award is Adi Satya Utama, given by Indonesian Doctor Associations or ED. Other affiliations are as the staff of Hospital Patient Safety Institute in Indonesian Hospital Association or PERSI, Chairman of Medical Tourism Development in the Indonesian Doctor Association or ED, staff in Professional Service Development Council in the Indonesian Doctors Association or ED, and also an expert in Public Health Office in IKASINDO or Indonesian Health Consultant Associations. Now, before we start with Dr. Mukti presentation, I would like to share first a video about Perketwi. Okay, so we will give the opportunity to Dr. Mukti to give his presentations about revitalizing medical tourism in Indonesia. Dr. Mukti, are you ready?
Yes, please.
Okay, good morning, Dr. Mukti. You have 20 minutes to give the presentations, and at the end, we will have discussion sessions. So, Dr. Mukti, the time is yours.
To the Honorable Professor and seniors in the Faculty of Medicine, University of Warmadewa, and all our colleagues who we are proud of. Good morning, Om Swastiastu, salam wisata sehat, wonderful, dan mempesona. Slide. Conceptualization of health tourism at the strategic policy level has been included in the government agenda setting, which was mentioned in the presidential speech report on August 16, 2021 ago. From the cabinet meeting, the president also gave direction that tourism has been designated as the leading sector in national economic development. On the other hand, the health tourism concept framework has also been seen by the Minister of Tourism, Mas Menteri Sandiaga Uno, as an opportunity in starting the stage of national economic recovery after the COVID-19 pandemic. For this reason, we from the Indonesian Health Tourism Medical Association persuade all colleagues who are gathered in the Specialist Medical Association, Subspecialist Medical Association, and the Medical Association of Interest. This is the time for us to collaborate together for making a paradigm shift and creating the opportunities in order to improve the competitiveness of the best services for Indonesian doctors. Slide. After the policy formulation process, scenario plans, preparation and strengthening policy implementation strategies in the medical tourism development PBED 2018-2021 period, and the 2021 Perketwi National Conference Agenda Realization, today Perketwi is conducting a relaunching structure and work program, so that in the future, this association under MPPK PBED can be more access in developing diversification of superior tourism services. As part of the medical professional services improvement carried out by Indonesian doctors to be more competitive and at the regional and global level. Slide. Indonesia health medical tourism development base consists of 5 service pillars. First, medical tourism based on excellence in specialist and subspecialist medical sciences. Second is wellness, aesthetic, anti-aging, and herbal tourism based on medical science and scientification of jamu. Third is scientific medical tourism. Fourth is sport tourism that support health based on sport medicine. And fifth, health sector support in priority and super priority destination based on emergency medicine. The basis for the paradigm shift of per capita management for the period 2021-2024 is described in our tagline, namely from medical services to Indonesian health tourism medical services. In this, the basic for building a frame of mind for the Indonesian Health Tourism Medical Association. In the future, it will be developed jointly with various associations into a conceptual framework that will produce a future service scenario along with its implementation strategy. Slide. Furthermore, in each scenario and its implementation strategy, we will always invite and involve all strategic pentahelix stakeholders related to the implementation and development of health tourism medicine to build the image that tourism is healthy, wonderful, and fascinating. We will create the new experience that are extracted from Indonesia natural wealth and cultural treasure that are integrated with other pillars, 5 pillars of medical tourism health services. Perketwi is part of the national interest, which will become a strategic partner of Fakultas Kedokteran Universitas Warmadewa with other multi-helix collaborative governance stakeholders, including the government, media, civil society, the business sector, academics, and other medical associations. We already have governance input in the form of human resources for Indonesian doctor spread across 89 specialist and subspecialist medical association and seminar medical association, which are the main modalities to improving the quality and diversification of medical tourism services in Indonesia. Slide. For this reason, with the spirit of fellowship and national interest, we ask you to collaborate to increase the power of the Indonesian medical profession at the national, regional, and global level through various superior service innovation. In building excellent services based on the 5 pillars, collaborative governance with specialists, subspecialists, and seminar medical association is needed to create various types of future excellent medical services. Thus, we convey, we hope that in the future, we can collaborate with the Faculty of Medicine Universitas Warmadewa to develop together a training curriculum to improve the ability of doctors who graduated from Warmadewa University as leading doctor of Indonesia Health Tourism Medicine. Thank you very much. Om Santi Santi Om.
Thank you, Dr. Mukti, for the wonderful and nice presentations. So, okay, for this topic of revitalizing medical tourism, I have questions, Dr. Mukti. First one, I would like to ask, what kind of medical service that is potential to attract traveler or tourists to visit Indonesia as medical tourism, especially during this COVID-19 pandemic?
Saya akan jawab pakai bahasa Indonesia karena sebagian besar adalah mahasiswa Fakultas Kedokteran Indonesia.
Ya, dokter.
Jadi pada masa pandemi ini kita membangun 5 pilar. Pilar medical tourism, wellness, estetik, anti-aging, dan herbal tourism. Ada medical scientific tourism, sport health, dan health sector support in priority and super priority destination. Nah, di dalam masa pandemi COVID ini, kita tahu bahwa terjadi penurunan traveling wisata. Namun sebenarnya ini merupakan challenge dan opportunity bagi mahasiswa Fakultas Kedokteran dan sivitas akademika yang ada di Warmadewa, serta para dokter, khususnya dokter yang ada di Bali. Karena apa? Menteri Parekraf, Mas Sandiaga Uno, itu sangat concern. Bahkan pada saat beliau itu memberikan keynote speech pada Universitas Udayana untuk melaunching wellness tourism di Bali, telah menetapkan Bali menjadi pusat integrasi medical tourism dan wellness. Itulah yang menjadi prioritas Bali. Karena Bali memiliki banyak sekali destinasi wellness yang dapat dikaitkan dengan pelayanan medical tourism. Perana misalnya, dikembangkan di Bali. Jadi hasanah budaya yang ada di Bali, yang dimiliki oleh komunitas masyarakat Bali, itulah yang menjadi basic, yang menjadi modalitas utama dari Pulau Bali untuk mengembangkan wellness dan herbal yang tersaintifikasi, yang merupakan ciri khas spesifik dari Bali. Itu prioritas utama. Dan itu dapat dibuat kemasan dengan diintegrasikan dengan pelayanan medical tourism yang ada di rumah sakit rujukan yang ada di Pulau Bali. Ini adalah pengembangan yang dapat dilakukan dalam jangka pendek. Yang kedua, prioritas kedua adalah health sector support in priority and super priority destination. Kita ketahui bahwa Bali adalah priority and super priority destination tourism in Indonesia. Nah, apa yang dapat disupport oleh sektor kesehatan dalam rangka mendukung medical tourism Bali? Pemeriksaan PCR yang paling mudah saya ilustrasikan, itu dilakukan oleh sektor kesehatan. Kemudian juga dapat juga menciptakan event sport health di Bali. Dulu itu zaman dulu ada Bali 10K, lari 10 km. Nah, kemana itu sekarang? Hilang itu sekarang, nggak ada. Nah, kita bisa menciptakan event sport health berbasis kedokteran olahraga. Saya tahu di Bali ada dokter-dokter spesialis kedokteran olahraga yang dapat meng-create event seperti halnya Bali 10K yang dulu merupakan legenda dari event olahraga di Indonesia. Nah, kita bisa menciptakan itu bersama dengan Perketwi. Universitas Warmadewa berkolaborasi dengan Perketwi untuk menciptakan destinasi-destinasi wisata tersebut. Mulai dari wellness and herbal sebagai prioritas sesuai dengan karakteristik Bali, diintegrasikan dengan medical tourism. Kemudian kita dapat membantu untuk melakukan support terhadap destinasi wisata. Kita bisa mengadakan vaksinasi massal agar seluruh masyarakat Bali itu lekas cepat untuk mendapatkan herd immunity dalam pandemi COVID ini. Sehingga demikian kalau itu sudah herd immunity, tren kasus positivity rate di Bali itu nanti akan turun, maka wisata itu nanti akan berkembang kembali di Bali. Kita juga bisa menciptakan event-event sport health, dan kita bisa menciptakan medical scientific tourism yang bisa kita lakukan bersama dengan seluruh perhimpunan kedokteran di ID wilayah Bali. Demikian Dr. Komang, terima kasih.
Ya, terima kasih Dr. Mukti untuk jawabannya. Sangat menarik sekali ya, Dok ya. Ternyata karena memang Bali itu udah istilahnya terkenal ya sebagai destinasi wisata di Indonesia, jadi salah satu prioritas ya Dok ya untuk medical tourism.
Ya, betul.
Ya, oke. Ya, kepada para hadirin, apakah masih ada pertanyaan lagi untuk Dr. Mukti? Oke, mungkin saya ada satu pertanyaan lagi, Dr. Mukti. Oke, karena majority partisipan Indonesia, mungkin saya juga akan bertanya dalam bahasa Indonesia. Pertanyaan adalah, apakah pendapat Dr. Mukti mengenai travel bubble? Apakah kira-kira travel bubble ini bisa kita adaptasi di Indonesia? Seperti itu, Dok.
Kami belum mempelajari secara detail tentang travel bubble. Tapi bagi kami dari Perketwi, kami sudah berhubungan dengan Dr. Mayesti dari Universitas Warmadewa untuk melakukan kerjasama antara Perketwi dengan Universitas Warmadewa. Yang penting dilakukan oleh Civitas Akademika Universitas Warmadewa, kita bisa melakukan kolaborasi dalam rangka untuk meningkatkan soft skill daripada rekan-rekan lulusan alumni Universitas Warmadewa. Sehingga nantinya alumni lulusan Universitas Warmadewa adalah dokter yang sekaligus memiliki unggulan di bidang wisata kedokteran Indonesia. Jadi sebagai akhir dari sesi ini, dengan ini saya membuka peluang, saya terbuka bersama dengan seluruh tim di Perketwi, dan kami sudah membahas setiap minggu dengan bidang diklat Perketwi yang juga memiliki kompetensi di dalam peningkatan keunggulan peningkatan soft skill dari dokter-dokter lulusan Perketwi nanti. Sehingga nanti akan menghasilkan lulusan fakultas kedokteran, mahasiswa fakultas kedokteran, lulusan dokter Perketwi yang memiliki keunggulan dalam pelayanan medical tourism, baik itu secara manajemen maupun soft skill. Itulah yang nanti dapat kita kemas bersama dengan Universitas Warmadewa. Karena saya punya waktu sedikit, saya mohon izin untuk menyampaikan ini. kami terbuka dan kami menunggu tahapan selanjutnya untuk kita bisa bersama-sama mengembangkan tersebut. Tentang travel bubble, nanti bisa kita dalami bersama dengan Universitas Warmadewa supaya kita bisa menyusun konsep travel bubble Indonesia, khususnya konsep travel bubble yang ada di Bali, yang itu nanti dapat menjadi sebuah keunggulan bagi Bali untuk dapat dilaksanakan, dimotori, digagas oleh Fakultas Kedokteran Universitas Warmadewa. Saya akan menunggu dan mari kita jadikan travel bubble itu sebagai salah satu prioritas yang nanti akan menjadi kerjasama antara Perketwi dengan Universitas Warmadewa dalam rangka untuk mensupport priority and super priority destination di Bali. Konsepnya seperti ini, strateginya ini, kemudian implementasinya seperti ini, dan itu dilakukan menggunakan resources yang ada di mahasiswa Universitas Warmadewa. Itu nanti akan menjadi sebuah unggulan yang kita ciptakan. Demikian Dr. Komang, terima kasih.
Terima kasih Dr. Mukti atas jawabannya. Terima kasih juga sudah memberikan peluang ya, kesempatan untuk kerjasama dengan Universitas Warmadewa, karena memang visi misi kami adalah di kesehatan wisata. Oke, ya terima kasih Dr. Mukti.
Ya, saya izin menyapa Prof. Tuti Parwati. Beliau adalah Ketua Perketwi Bali sebelumnya, senior saya, dan beliau saat ini adalah Dewan Penasehat. Dan selamat Prof atas selamat atas terbentuknya Perketwi Bali, dan kita bisa merelaunching seluruh konsep ini bekerja sama dengan seluruh fakultas kedokteran yang ada di Bali. Tidak hanya Warmadewa, Udayana, kemudian Ganesha, semua. Mari kita berkolaborasi untuk menciptakan sebuah produk layanan unggulan health tourism Indonesia. Terima kasih, Prof.
Terima kasih Dr. Mukti sudah merelaunch ini, mengumumkannya di sini sehingga tambah semangat untuk Warmadewa dan yang hadirin sekalian. Terima kasih.
Okay, thank you Dr. Mukti for the nice presentations and also the nice discussions about medical tourism in Indonesia. So now we will start with our 5th symposium with topic infections threat at the destination. For this symposium, will be led by Dr. Diwayan Wididewi, MBiomed. So now I will first of all read her briefly CV. So Dr. Widi has graduated as medical doctor in the Faculty of Medicine, Universitas Udayana in 2013. She is also graduated as a Master of Biomedical Sciences from Faculty of Medicine, Universitas Indonesia in 2018. Her current position is lecturer at Department of Microbiology and Parasitology in the Faculty of Medicine and Health Sciences, Warmadewa University. Research interest is about respiratory viruses. So, Dr. Widi, the time is yours.
Okay, thank you for the MC for introducing me. In this session, we have 2 key speakers, which is Dr. Yandri Wijayanti Subronto, MD, PhD, internist infectiologist, and Dr. Paulus Novian Haryanto, SPPD, KPTI, Finasim. And then we will have 15 minutes of plenary discussion after the 2 presentations. Okay, first, I would like to introduce Dr. Yandri as the first speakers. Okay, Dr. Yandri's academic background are PhD at Leiden University, the Netherlands, 2002, and then internal medicine specialist Faculty of Medicine Universitas Gadjah Mada 2007, Fellow of the Indonesian Society of Internal Medicine, FINASIM, at 2014, and Infectiologist Consultant of Tropical and Infectious Disease 2015. Her current positions are Head of HIV Division, Center of Tropical Medicine, Faculty of Medicine, Universitas Gadjah Mada, and then Vice Director of Postgraduate Studies and Learning, Directorate of Academic Affairs, Universitas Gadjah Mada, Head of HIV/AIDS Team, Dr. Sarjito Hospital, Yogyakarta, Head of Expert Board in the Association of Indonesia Health Office. And then her publications are first, nevirapine and tuberculosis predict first-line treatment failure in HIV patients in Indonesia, case control study 2020, HIV self-testing for men who have sex with men, an implementation trial in Indonesia 2021, a strength-based analysis of social influences that enhance HIV testing among female sex workers in urban Indonesia 2021. Okay, for Dr. Yandri, are you ready?
Good morning, Dr. Widi.
Good morning, Dr. Yandri. Doctor, you have 20 minutes for presentations. Okay, the time is yours.
Okay, thank you, Dr. Widi, for the warm introduction of me. Firstly, I have to thank Dr. Masheni for inviting me in this webinar on travel medicine. And of course, I also pay respect to my senior, my guru, Prof. Tuti Merati. Yeah, in my early days as a clinician, I always call her, and I have this kind of patience. What should I do? And, yeah, so thank you, and again, thank you for all the my new colleagues now in Warmadewa. And secondly, I would like to say I envy the last conversation from Dr. Mukti. He is inviting all the graduates of Faculty of Medicine in Bali to be able to work on travel medicine. And if I may register myself, can Gadjah Mada be one of it as well? Yeah. Okay. So good morning, everyone. I see, I guess, some juniors of mine in here. Let me go to my first slide. Allow me to share my slide. Okay. Share screen. I have 20 minutes. Yeah, Dr. Widi. I will try to do it in 20 minutes. Okay. I think I'm going to follow what was the last conversations between Prof. Tuti and Dr. Widi. Even though now it's a pandemic era, but hoping that we are approaching to somehow reverse it from the pandemic into the endemic era. But then again, with this kind of situations or with this good situations, I guess tourism will be starting, hopefully, not only in Bali, but it also will be in Indonesia. And one of the threat of traveling, especially to, I'm sorry to say, to Indonesia, is the worriness about travel-associated enteric fever and GI infections. I hope I get this correct. And let's talk about this, about what is actually in Indonesia is one of the endemic area. So if we were going to see this world map, this is kind of, as everyone can see, this is airplanes. And of course, this one is taken, or this, of course, this photo is before the pandemic era. But this might happen again within the not too long time. Traveling will be so much easy. And as everyone can see, Indonesia is now on the world map, either on the vaccinations and of course in the tourism. I think wonderful Indonesia is already becoming a trend in the world, and also there is a movie, or there is a event in the National Geographic People, is the wonderful Indonesia cuisines. So okay, let's be ready to receive many people coming to Indonesia. Okay, what is enteric fever? Enteric fever is also known as a typhoid fever, and I think everyone in here, I guess we should know. Unfortunately, typhoid fever in the, how do you say it, in the competence level, you have to masterize it for all the graduates of medical students, but we don't have many cases anymore in the type A hospital or in the teaching hospital. Everything has to finish in the first level of health facilities, or at maximum at second level of health facilities. So I guess we don't really have that many patients anymore in the type A hospital. But actually, as mentioned in the .3, this is actually a public health problem. Public health problem. If we were already in the clinic or in the hospital, we just have to give antibiotics, that's it. But then the problem is in the community, because this fever, or the typhoid fever, is acquired through fecal contaminations of food and water, especially this particular time of the year where there is a poor water, and just be careful with it, and you have to warn your colleagues or your friends and your guests, because this is associated with poor hygiene conditions and inadequate sanitations. If we were in the city, maybe this is not happening, but remember, we have so many warung along the trottoir. They don't have a good clean water all the time, right? So the transmission is food or waterborne transmissions result from fecal contaminations by ill or asymptomatic chronic carriers acquired during travel to developing countries. It says developing countries, yeah, because maybe it is relevant with the hygiene condition. And then there will be some outbreaks at the time points of the year, something like that. So what we can do is the improvement of sanitations and living conditions, including treatment of drinking water, have a significant contribution to decrease the incidence. Well, luckily now that the government, the central government, is building more healthy houses with a proper treatment of drinking water. What causes this is the Salmonella typhi. It is ingested or contaminated food or water, contact with an acute case of typhoid fever. So if you are thinking of it, it's not only the SARS-CoV-2 that it's human to human, but this is also can be human to human in terms of there is a water or food that is contaminated with a person who might be carrier. Water is contaminated where inadequate sewerage systems and poor sanitations, or contact with a chronic asymptomatic carrier. In the early 90s, in the early years of 90s, we have what we call the, how do you call that? It's the, I guess Dr. Paul would know, my senior. There's the case of Mary, who is a cook, and turns out she infected 53 people, and then some people died out of being her cooking, and turns out she is a carrier. How does this bacteria cause diseases? It is ingested, carried by white blood cells into the liver, spleen, and bone marrow. So that's why we have the culture for bone marrow is one of the go-to diagnoses. And it can multiply and re-enter the bloodstream. So that's why it can become a clinical illness, and it can be a systematic illness. Bacteria invade the gallbladder, the biliary system, and the lymphatic tissues of the bowel and multiply in high numbers. Then pass into the intestinal tract, can be identified for diagnosis and cultures from the stool, and then can lead to complications. Some of it would be a perforations or a hemorrhage. So this, be careful with this. This is kind of the schematic of what I just mentioned. I will just pass this one. What is the epidemiology? It turns out that even though we as the one who works in the type A hospital don't see it that much, but actually the global estimates noted more than 21 million incident cases and 222,000 related typhoid related deaths. The most prevalent one is the Indian subcontinent and the Southeast Asia, show the highest annual incidence, more than 100 cases per 100,000 cases annually, followed by the Southern Africa. In high-income countries, this is an interesting statement. In high-income countries, typhoid fever is one of the most frequently diagnosed vaccine-preventable diseases in return international travelers and migrants coming from high-incidence countries. So this is very relevant with what we are talking in travel medicine, because in the US, in Canada, and Europe, they don't have it as an indigenous or a local context, but it is from those who comes from who were returning from international traveling, especially from the high incidence countries. Unfortunately, Indonesia is one of it. Is stated to be one of the high endemic area of typhoid. So if we were in the estimated that the incidence of travel typhoid fever in travelers to high endemic countries is 3 until 30 cases per 100,000 travelers. Well, it is already a lot and can cause economical values as well. So these kind of the map. And then I just want to point out the third dot point, length of stay, increased risk. So not only where you go, but it's also how long you go in that specific area. So what would be the symptoms? It can be very mild, and then they become couriers. But also it can become that they become poor appetite, headache, especially because usually bacterial as well causes headaches, and then lethargy, fever. Fever is one of it. Rose spots in some cases. Maybe for the white people, we can see it, but not the colored people. Diarrhea will be one of it. So it's mainly because it was going to the plaques pylori in the intestinal. So that's why there's so many GI tract symptoms. But then there's also, because I mentioned earlier, this is a systemic diseases. It can also lead into the to other places. Chest congestion means that it can be because of the nature of the systemic one. And then there's also the slow heartbeat and enlarged spleen and liver. So for those who are medical doctors, you always have to touch the patient's spleen and liver, especially in the fever patients. The incubation period is around 6 until 30 days, so it's long. So that's why you have to ask how long have you been in an endemic area, when did you come home, and what happened in there, and what did you do, so things like that. So headache, malaise, a fever up to 104 degrees Fahrenheit, increasing the severity, low-grade septicemia, rose spot on trunks may be happening, and GI tract symptoms, serious complications within 2 or 3 weeks, hepatosplenomegaly, and also the hemorrhage or perforations, of course. How can we, the clinical diagnosis for typhoid is, okay, I guess anamnesis and physical examinations is very important. It can lead to a first differential diagnosis if you have a patient with a fever coming from high endemic areas, especially for travelers, and then go for the hepatosplenomegaly, find it, the rose spots, and all these things, and you can suspect this is kind of a typhoid. There's an ache, there's pain, there's diarrhea can also happening, and this is the typhoid that is very severe and leads to meningitis. The severity depends on the host factors, whether or not there's immunosuppression, anticytic therapy, previous exposure, vaccination status. So we are talking about vaccinations not only for COVID, but now we are going to talk about the Salmonella typhi vaccine later. Strain virulence and inoculum, and then choices of antibiotic therapy. I mentioned a few things about complications. It can also include neurological manifestations. Other conditions that might mimic, remember, we might travel to high endemic areas for TB, Salmonella typhoid, but it can also the same endemic area for malaria, which will be talked thoroughly by Dr. Paul later. And then fever, usually there's also a dengue fever. Now it's kind of the time as well. The leptospirosis might be the same, have a kind of similar symptoms and signs in the early days of symptoms. Who are at risk? Firstly, travels to high endemic countries, mostly visiting friends and relatives. So this, I put this here because there's a study whether a business traveling or visiting friends and relatives would be differs in terms of the risk. And it turns out VFR, traveler, is somehow one of the highest risk, that is visiting friends and relatives, because if you visit friends and relatives, you go out to warung and then have fun with the food and drinks. So you forgot about sanitations. Okay, and then who are at risk, especially those who are have a decreased either stomach acidity, and this is the conditions. Those who have a decreased intestinal integrity, like the IBD or prior GI surgery and all of that. And then immunosuppressions, including HIV infections, can be one of it because it is a cell-mediated immune response. Diagnosis, clinical examinations consisting of anamnesis and a good physical examinations. And then now can we talk about the laboratory? What would be the laboratory to use for detecting or making sure this is typhoid or not typhoid? So serological diagnosis can be detections of antibodies itself or detections of the antigens in the serum, can be in the serum or in the urine. Okay, so antibodies, you have the WIWTM, and then there's a two-pack system, and then antigens is as well. Sorry, Dr. Widi, how many minutes do I have left?
You have 6 minutes left, Dr. Yandri.
6?
6, yeah.
Okay, yeah, so I'm counting my slides. And then you can also detect it from the urine. Okay, these are some of the diagnosis or the methods that you use for diagnosis. Blood culture, yes, this is especially it's like the Koch postulate. If you find the bacteria and you have a disease, so you say this disease is caused by this. So that's why if you can find it in the blood culture, will be, it's kind of a golden standard. And especially in the secondary phase, that is bacteremia, and then stool culture, less effective, but diagnosed in the second and the third week. And both bone marrow, remember that the bacteria can also go to the bone marrow. So it is the golden standard for typhoid diagnosis, but it is invasive. You ask the patient, can I do a bone marrow puncture? And we want to try to find the Salmonella typhi there. It's costly, it's expensive, and very invasive. So usually it's kind of one of the last one that we use for diagnosis. The WIWTM test, it's been in the world for many years. It's a serological test for enteric fever, detects antibody against old and aged antigens. And then in here it says that antibody titer of greater than 1 per 160 and greater than 1 per 80 for antigen, anti-H antigen, and anti-O antigen, respectively, are considered as a cutoff level to predict recent infections of typhoid fever in endemic area. So you see the titer. But it is not reliable due to its common false negative and false positive, poor agreement with blood culture, and poor performance. That's why many of you now only kind of know about 2-PEX TF, typhoid fever test. So it's a semi-quantitative to detect acute infection because it is seeing the antibody IgM. So that's why it's more acute. And then the other is PCR, but it is also costly. I just add this. I just got it, and then put it here, mendeteksi hanya antibodi IgM terhadap saluran TV yang mulai muncul pada hari ketiga sampai keempat demam. So it can be detected in the early days of the fever. So that's why we can use it to diagnose early infections. Treatment. Don't forget to do the supportive treatment. If there's a diarrhea, avoid dehydrations. And antibiotics, actually, there are so many common antibiotics. It doesn't have to be a very highly, the recent antibiotics. We can still use the ampicillin, the chloramphenicol, fluoroquinolone, cotrimoxazole, amoxicillin, and ciprofloxacin. Prompt treatment of the disease with antibiotics reduces the case fatality rate to approximately 1%. But then if you have a case of severe enteric fever characterized by neurological symptoms, it can be, we can administer the corticosteroid such as dexamethasone and at initial dose of 3 milligram per kilo and then followed by 1 milligram per kilo every 6 hours for 2 days. Now, choices of antibiotics, we can see it here. Ciprofloxacin, but then remember there's an emergence of multi-drug resistant strains. So the first line treatment was represented by third generation cephalosporins such as cefixime. The alternative drugs was the chloramphenicol. This is kind of an old drug. We don't really use it that much anymore with some of the side effects. And the cotrimoxazole we can still use. And then I just want to show a few slides. If we were fully susceptible, first line oral drug would be fluoroquinolone, second line would be chloramphenicol. Everyone can see this one. If you have the multi-drug resistance, you go into the fluoroquinolone, or the second line would be the azithromycin, or the third generations of cephalosporins such as cefixime. If it work with quinolone resistance, then you go to azithromycin or a third generation of cephalosporin. This is for the severe cases of typhoid. You go with the fluoroquinolone. I will just run through it. Concerns with the antibiotics for resistance of antibiotics. So use the adaptation or adopt the antimicrobial susceptibility testing in your area. Okay, use what is already known there, whether it is resistance or not, or is it still sensitive. This is just to show the clinical breakpoints. Like if you work with the microbiologist, then you have to know whether this is sensitive, it is intermediate, or resistance. Okay, avoid the grip of the typhoid hand. If you see this is an old picture. Avoid the grip of the typhoid hand. This is relevant with the pandemic now. Avoid the grip of the COVID hand, something like that. If someone is already having a droplet somewhere and then just and you touch it, then that's why hand washing is one of the very key to avoid typhoid fever. Prevention and treatment, there are two things: vaccinations and be vaccinated against typhoid while traveling to a country where typhoid is common. And then you have to complete it before traveling, and then it is effective for several years. So ask whether you have to do a booster after 2 years or 3 years. And then just this one, a typhoid vaccine, it can be an oral vaccine or it can be injectable vaccines. The oral vaccines can be given to those age 6 or older. It can have protections until 80%. And then you have to complete it 1 week before traveling and revaccinate every 3 to 5 years. The injections as well, this one can be used at the age of 2 or older. Protections about the same, completed before 2 weeks before exposures, and then there's a booster. And then this is, of course, the two last slides is avoid risky food and drinks. Buy bottled drinking water. As for drinking without ice, unless you are very sure it is the sanitations and water treatment as well in that restaurant or something. Eat food that have been thoroughly cooked and that are still hot and steaming. Avoid raw vegetables and food that cannot be peeled like lettuce. Well, avoid means that if you are unsure whether the place is hygienic enough. Okay, this is the last slide of mine, is the checklist for evaluating fever in return traveler. Maybe you will receive traveler who just been traveling to other countries, so and he comes to you or she comes to you with a fever. It is not a return traveler, but it is also a traveler. Well, you can ask, where did you go? How long did you go there? Maybe they go to Africa or they go to India or something like that. Did you ever receive the immunizations before traveling? Was there any exposures? Maybe you know that your friend is also sick. Did you have a sexual intercourse? This is the local during travel. This is relevant with the STIs, including HIV. Here is the number 4. What were their food and water exposures? This is relevant with the typhoid. Did they have any illness during travel? Did they take any medications? And they have they been exposed to any illness since then? Wrap up. The enteric fever is still a public health concern in the world. High endemic countries include Indonesia. It is transmitted via fecal-oral modes, usually related to poor hygiene and sanitation and water treatment. Travel, particularly to high endemic area, is one of the risks for being infected, but it can be avoided by vaccinations and making sure that you have that you take a good food and water that should be hygienic. And you can also, the last one, follow international regulations for travel. So with that, I end my presentation. I hope it was useful for all of us. I give it back to the moderator. Thank you.
Okay, thank you so much for Dr. Yanri for the nice and clear presentations. Okay, and now for the second speaker in this session is Dr. Paulus Haryanto, SPPD KPTI Financing. First, I would like to introduce him. Okay, the academic background of Dr. Paulus is medical doctor, Universitas Gadjah Mada, 1973, and then internal medicine specialist, Universitas Samratulangi Manado, 1995, consultant of tropical infectious disease, 2000, and then his current positions are Chairman of Medical Committee, Bethesda Hospital Tomohon, Chairman ICP, ASP, Geriatric, TB Program, Bethesda Hospital Tomohon, External Lecturer, Departemen Internal Medicine, Universitas Samratulangi Manado, and then member of National Expert Committee on Malaria Therapeutic and Prevention, Ministry of Health. And his job experiences, he's a medical staff and senior clinician in Bethesda Hospital and Anugerah Hospital in Tomohon. Okay, Dr. Paulus, are you ready for the presentation?
Okay, thank you, Dr. Widi Dewi as a moderator.
Okay,
Now my voice is clear?
Clear, Doc.
Okay.
Okay.
I think my presentation will be shared by you or by other staff. My slide, okay?
Okay, I will open your slide first.
Okay. Firstly, I would like to thank the organizing committee who invited me to talk in this event. This is my 3rd time with Warma Dewa doing the travel medicine and international symposium. And that's why I would like also to thanks to Dr. Masyani, and also we should not forget with Dr. Professor Tuti, who is my senior in the group of KPTI. Just now we just listened Dr. Yandri in typhoid disease, but malaria is still not left behind, because malaria is still a fancy disease. As we all know that in the next month there is a national event in Papua that will be more than 3,000 tourism going to the Papua. As you know, that Papua is a area that malaria is still endemic in this country. Don't be afraid with the malaria. That's why today I want to talk about the progress of malaria control, treatment, and elimination. Next slide. Yes, this is what the government doing in the malaria control program. The malaria control program consists of several actions. The most important is diagnostic. So we are successful in making the early diagnostic and good treatment. So the evidence of malaria will decrease since 2010. And beside the diagnosis, of course, the treatment will be important. And then the next thing is doing a surveillance, particularly in the high and moderate endemic area. And of course, after that, we should doing the countermeasure to fight with the vector surveillance, particularly again in the area where malaria is still endemic. And the final step is about the advocation and communication and education. Everybody should understand about the malaria infection. Next slide. The slide here is show you about the how endemicity our country in malaria infection. And this map is since 2018. As you know that actually in Indonesia, a lot of part is already not really high endemic. See, some the area with white is quite free or low endemic infection malaria, and only the area with the red, mostly in the east part of Indonesia, is still highly endemic. Next slide. And this is the report, the last report in 2020. So we understand that 80% of Indonesian people actually living in the free area of malaria. So don't worry if you stay in Indonesia. And that's become because of 62% of our city or our district is actually malaria free. As you know that since the government doing the good treatment and diagnostic, the malaria cases is reduced since 2010, where in the past our index in the annual parasitical parasit index is still above 1, and then slowly reducing until the 2015. This the lowest number is 0.84, and since then is stagnant until now. The number is around 0.8 something. This is a national number. So what we understand, and that AP, annual parasite index, meaning that we are still have to work hard to reduce, to make it lower, is to fight in the some province where the malaria is still endemic. Next slide. This is the report also to let you know that our achievement in the malaria control program. This is show you that some area of Indonesia, a lot of area with the free malaria. If you know here in the regional Jawa, Bali, this most area is area of free malaria. And the second thing is the regional Sumatra and Sulawesi. this almost 67% area is already eliminated. Only some places in the east part, namely in the Papua, that the elimination is still very hard. So we are now is work hard to make it all the district and city become malaria-free area. So with this achievement, we classified our endemicity become a red area was highly endemic, and then yellow area is moderately endemic, and the green area with low endemic, and the white area is area with a free malaria. Next slide. This slide show you that we still have malaria cases in Indonesia. And 80% of our cases is mostly located from the 4 provinces in the east part of Indonesia, whereas the province is Papua, West Papua, and East Kalimantan, and then East Nusa Tenggara. Yeah? This is the 4 provinces we are still have a high endemic area. So the others area, like you know, in the right side, like Bali here, Bali is still have cases that about 17 cases in 2020. This cases mostly is imported, and I heard that some cases are also from outside of Indonesia, like from Africa and so on, who doing traveling to Bali. In my area itself, in North Sulawesi, we still have a lot of cases. It's almost 1,000 cases. Is some is endemic and some is imported. So we are still having cases of malaria until 2020. Next slide. How about the malaria diagnosis and treatment? This is my talk in the second part, because malaria diagnosis and treatment is important in the making elimination malaria in Indonesia. Next slide. We have a guideline, yeah, in which the most doctors have in Indonesia have to follow with the guideline. The guideline from Ministry of Health, what we call it the PNPK, Pedoman Nasional Pelayanan Kedokteran in Management of Malaria, and that's have to be summarized in the violet, the pocket book, and the behind that is the 2020, and actually all the guideline is still looking the base with the guideline from WHO and 2015, and also the recent WHO guideline is July 2021. Next slide. This is basically of the treatment in Indonesia. All the malaria, either Plasmodium falciparum or Vivax or others, have to use ACT plus primaquine. ACT, what we use in the ACT is dihydroartemisinin piperacin. This is very powerful drug, and it's very easy to use. This is 3 days doses, and the primaquine doses is depend on the which Plasmodium we found. If falciparum, we should use primaquine 15 milligrams in day 1. That's only single dose. And for Vivax, we use 14 days, 50 milligrams a day. Previously, we used artesunate amodiaquine. We are not using that drug anymore because a lot of compliance. And amodiaquine is derivative of the chloroquine, in which the some area in Indonesia is already resistant with that combination of ACT. The other ACT may be found in Indonesian is artemether lumefantrine. Next slide. This one of the example in the table of treatment. Next, please. Yeah, this is table about the treatment of malaria falciparum and vivax. We should use according to the body weight, because in cases with obese or malnutrition, it's very difficult to use according to age. Maybe this is not fit enough with the doses. So the doses should be used according to the body weight. And for falciparum, we use only single dose. And for vivax, we use for 14 days of primaquine. Next slide. This should be considering and make it attention, in which we should use body weight to making the doses of DSP. We should remember that primaquine should not be used in the pregnancy. In cases with the G6PD deficiency, primaquine could be used in 8 to 12 weeks with the doses 75 milligram weekly. Usually, ours in Indonesia not doing the test G6PD regularly. Maybe later on, we will use it G6PD to improve our treatment in malaria. For vivax, who always relapse, in these cases, we thought that we have failed on the treatment with usual doses of primaquine, so we can increase the doses to 0.5 milligram body weight for 14 days. Ovala, we follow same with the vivax, and malaria and non-LASI, we're not using primaquine because they are not having a hypnozoid form in the liver. Mixed infection, vivax with falciparum, the falciparum should be used, the primaquine should be used for 14 days, followed with the vivax. Next slide. This treatment for malaria and pregnancy, this is important because our guideline in Indonesia is recommended to use DSP ACT since the first trimester of pregnancy. If you're looking the last guideline from WHO July 2021, the WHO is still using quinine in trimester 1. So what we are doing here, that we are more confident, more going forward from the WHO program, that we are treat with our pregnancy with malaria since trimester 1 to trimester 3 with the DSP. Next slide. This is rescue treatment. According to the report in Indonesian, actually, we still make a good response with DSP that very rarely reported about the treatment failure. But in the guideline of Indonesian, we preparing the rescue treatment in case that we found that there's a malaria treatment failure with the DSP. We are using quinine plus doxycycline, tetracycline, and clindamycin. And for vivax failure in DSP, we only using the quinine without tetracycline and doxycycline. Next slide. This is another table. What I talked previously about the relapse vivax. We use high doses primaquine, 2 tablets for 14 days. Next slide. This is the treatment for severe malaria. The severe malaria should be treated with the artesunate intravenously with the dose of 2.5 milligram. In the first day, the dose will be 0 hours, 12 hours, then 24 hours. Then after that, every 24 hours. Minimally, we should give a parenteral treatment for first day or 3 times injection before we move to the oral treatment if the response is better. Next slide. My third part of presentation is about elimination policy and strategy. Next slide. Elimination means that we monitoring some area with no transmission, local transmission, human to human. And this should be present for 3 years. So if the one district declares malaria-free, we should monitoring that there is no human transmission or local transmission in 3 years. And the positivity rate of surveillance in that area should be less than 5%. Then API, annual parasitical index, should be less than 1. So that that kind of area can be declared as malaria endemic area. This is very hard to achieve that because sometimes some area only 1 year can prevent the malaria locally, but the second year they found a malaria infection. Actually, with malaria-free area, there are a lot of advantages for improving the human resources and improving also economical background and reducing the number of malaria infection. Next slide. So with the elimination strategy, the government divided our area become 4 area with the free area malaria. We have certain activity, and the area which is highly endemic, we have others activity, and also difference with the area with yellow and area with the green. Next slide. With this program of elimination, in the last report in 2020, Indonesia, we have 3 provinces is already free of malaria. It's Jakarta, East Java, and Bali. This actually good for all the people in Bali that has supported our program in the travel medicine, that we should not have malaria in Bali area. Okay, and then next slide. We still have a certain area with a very highly any places free malaria, namely is Papua, Papua Barat, and Maluku. In the last report in 2021, the North Maluku entity and North Maluku is become improving with some area having district or city is already free. So meaning that our program malaria is work hard to add and to release some area become the free malaria area. Next slide. Of course, in the high endemic area, we have a certain activity, and that's like a net mosquito program, IRS, indoor residual spraying, malaria screening in the pregnant woman, on treatment, increasing the cases with detection and improving registration of the cases, new cases. So with this activity, we hope that the area with highly endemic become low endemic or maybe become a free area. Next slide. And this is the slide show you our strategic activity and the goal and the elimination of malaria in 2020 to 2024. Our goal is 75% Indonesian territory is a free area transmission. This is already reached, but no high endemic district by the end 2024 is work hard for that, because we have still some area with highly endemic area. With the objective is decreasing the AP become below 1 and decreasing the number of city or area with AP more than 1 from the 61 to 13 by the end of 2020. This is very difficult. Increasing the number of free districts from 285 in 2018 to 405 by 2024, and malaria-free status in the district have to be maintained. Next slide. So with the goal and objective. Next,
Dr. Paul, you have 2 more minutes left.
Yes, this is my last slide. This is all the strategy and all the activity, 1, 2, 3, 4, and there is a key intervention. I don't want to read this one because the one is plenty activities. I think this is my slide, then my last talk. Thank you. Next slide. Okay, thank you, moderator.
Okay, thank you very much, Dr. Paul, for your nice presentation. And then we continue the session with the plenary discussion. Is there any participant have questions for the 2 speakers, Dr. Yandri and Dr. Paul? You can directly unmute yourself and ask questions. Okay, there is one question in the chat room. Okay, this question is for Dr. Yandri. What is the trend of typhoid in Indonesia and where are the hotspots? Please, Dr. Yandri.
Thank you. Thank you for the very nice questions. I don't really see a surveillance data, the national surveillance data on typhoid as a regular thing to report. And it seems, as I mentioned in my presentations, that we don't see it anymore in the type A hospital. That's kind of one of the problems. That is it underreported, or it is because that everything has to be solved in the primary healthcare. The hotspot probably is the hotspot. If you think of how it is transmitted, the hotspot would be, think of those areas where water sanitations might be still poor, and also about the climate. In here, like in Jogja, where would be the risk factors? The risk factors would be warung and all of that, and we have so many students going to warung, so you just have to be careful. The Dinas Kesehatan should also do a regular, monitoring of the water. I guess that's all I can say. I'm sorry I did not had a chance to really find a national data on the typhoid, whether or not there is a surveillance 3-monthly or something. Maybe Prof. Tuti or someone already a surveillance data on typhoid.
Yeah, Dr. Yandri, I don't know also about that surveillance, because typhoid fever, I think, is just endemic in the all part of Indonesia. Yeah, because we don't know also the how high the carrier stages among our population. it is a difficult surveillance to find out of the carrier rate in our population. But to keep in mind, we should be very careful in handling with food and drink in all our setting now, yeah. In every places, I think, because if we already have the food been cooked, but then how they serve, yeah, it's another problem also. Yeah, maybe there is a dusty and they don't cover it very good, something like that. So still we have to be careful and follow the advice on to keep how to choose food and drinking when we travel. Yeah, something like all the Dr. Yandri, when we choose a fruit, we have to peel. So a fruit that is still have the skin covered, or we have to wash, or also the food, if we can choose, so choose the food which is served accordingly before we have it, and or some food with covered with something like lemper and other covered with banana. So yeah, if we deal with the tourists, sometimes they in Bali they say that they will go to the market and they would love to see the colorful jajanan, yeah. So and all is open. So that is the critical event, I think. If we are we can tell or educate the guide travelers to ask them to do that, or as a traveler we have to consider that it is dangerous to have it. Yeah, I think that's my answer, adding to Dr. Yandri's. Thank you.
Okay, thank you, Dr. Yandri and Dr.
Thank you,
Prof.
Prof.
Tuti,
I
for the
tried
answer.
Dr. Viti, I'm also, while we are listening to Prof. Tuti, actually, I also try to find something on this, and there's no surveillance, any data on surveillance in Indonesia. I tried to look in the website of the Ministry of Health, and I tried to search with the surveillance data. I don't really see it. So thank you, Prof. Tuti, for mentioning the risk factors, especially in small hotels. Just be careful with water.
May I edit something about typhoid?
Yes.
Yes,
Okay,
please.
I agree with Janri and Prof. Tuti. We rarely heard about epidemic or endemic explosion in our area, but we still have a typhoid infection. You know, some of cases usually go straightly to the emergency, and
Yes.
surgical cases we already perforated. That's mean that the cases of typhoid is hiding. Lucky that we are in Indonesia. Most people is well educated with wash the hand, managing the food healthier. But some of cases still having. The other second problem is people using their own antibiotic, buying in the store, and that make it the diagnosis typhoid more become slowing, and finally become complicated, perforated. That's accidentally we can have this kind of cases. Thank you.
Thank you, Prof. Yeah, I guess you might see it in Puskesmas or in the secondary level of referral hospital, but not in the type A. Only that we don't find the formal surveillance data. That's what I'm trying to also try to find. Thank you, Prof, to raise the issue of out-of-the-counter medicine or self-medications with antibiotics can also mimicking or masking the burden of typhoid here. Thank you.
Okay, thank you.
Related.
And there are several questions in the chat for Dr. Paul. The first is, how is the best way to make decision to give chemoprophylaxis for adult international traveler? Better to choose weekly or daily dose?
Okay.
Yeah. And then one more related question, in relation to the first question, suppose expatriate living in Bali plan to do missionary for 2 years in Papua. Will you recommend malaria chemoprophylaxis for 2 years?
Yes.
Okay.
Okay. That's all. Yeah. I answered the last question first. About the people who want to stay longer period in the endemic area, say I would not recommend any prophylaxis, because the side effect of chemoprophylaxis is actually it's not good, because a lot of side effect. If you want to stay longer, it's just using the. It depends where is you want to stay. I hoping that they are staying in the city area. Is no need to chemoprophylaxis. That watch for the symptom of malaria and go to the early treatment to the health facilities. The first question regarding chemoprophylaxis for tourism, actually, the best chemoprophylaxis actually Malaron. It's a combination between atovaquone and proguanil, but we don't have that drugs. We should buy it outside of Indonesia. This is more, this is effective and easy to use. 1-2 days before coming, 7 days after releasing from the endemic area. So this is simple, then the side effect is less. But other drugs, like toxicity, and usually we recommend in our guideline, this is very hardly to use by the people, because it's a longer duration and the side effect is actually very difficult to accept that. In fact, in the point we just discussing about chemoprophylaxis, the decision to use chemoprophylaxis depend of the olahragawan, to the sportsman itself and the official, because we do not want to be blamed that using chemoprophylaxis making the effort, making the activities become not reaching the championship. This is we do not want to be blamed by that one. So we are not recommending, but we're recommending to avoid mosquito bite using the everything, bed net and so on. The chemoprophylaxis actually it's very difficult because we do not have suitable drugs here. Okay, Dr. Vidi.
Yeah, thank you, Dr. Paul. There is one more question related to treatment. In the treatment of pediatric reflux, I see you use tablet fractions. Would you like to see dispersed tablets or granules? And of the two, which one will be easier to give?
I cannot get your question, please.
Okay, in the treatment of pediatric reflux.
Pediatric reflux, yes.
Yeah. You use tablet fractions. Okay, and the question is, would you like to see dispersed tablet or granules? And of the two treatment option, which one would be easier to give?
Well,
dispersed tablet and granules.
Granule, you mean?
Yeah, granules.
Yes, yeah. We actually do not have a granule tablet. We are still just discussing about the granule, or what we call it, effervescent tablet for pediatrics. Hopefully, in the next coming years, our guideline will mention about it, but we're still discussing, because a lot of things we should considering if we want to accept for the program. So I don't think that you can have it granules tablet in Indonesian at the moment. Okay.
Okay. Thank you.
Can I ask Dr. Paul, and because I maybe didn't catch your about the chemoprophylaxis. What do you suggest to ask for the what is the Asian Games or other games would be held in Papua? So maybe people have the athletes have to come to Papua maybe weeks before, or maybe 2 weeks before the event, and also would stay to would like to stay after that. So as a doctor, how what is your suggestion about the regarding the chemoprophylaxis?
That's probably that's until last week we still fighting about that kind of issue in the Comly. Actually, our guideline recommend using chemoprophylaxis is doxycycline. Doxycycline should be used 1-2 days before left, and then during your staying in Papua, and then after releasing from Papua, you still use doxycycline for 1 month. That's very difficult, yeah, to believe that people will follow until 1 month. This is really very hard. Second thing, if we want to advise athletes to use doxycycline, for example, we know all the drugs. Yeah, we know the drugs actually having minimal side effect, but the athlete will say, because I'm taking the drugs, my stomach become aching, and I can't make a running. That's very difficult. The decision, we are not want to be blamed about it using doxycycline and they are not become a winner. This is very hard. So the decision we leave it them to the official or to the athlete itself. We only advise, please not to be bite by the mosquito, whatever how you do it. Okay, don't go outside in the evening using the long leaf, using the everything, but the health official in the Papua preparing all the area will be free from the mosquito, hopefully like that. That's we only promising. This is very difficult to judge. Until last time, we try to get the malaron for the athlete, but it's not possible.
Not possible.
Who should be taking? 1,000, 3,000 of athletes were coming. This is headache, you know. But we said, lastly, when I discussed with the health official in the Papua, please make a meeting with all the doctors of the contingent, because if there is an athlete sick or the official, will be first people is the doctors in the contingent. And doctors contingent should be know about malaria, should be know how to treat malaria, should be know how to get help if the athlete become going to sick. Now, this is our warning about them. Okay? Because malaria is easy. If you know malaria, just 3 sample is gone. Malaria is not like a COVID. Malaria no sequelae, you know. Don't be severe malaria. Early detection, early treatment, this is finished. We have very powerful drug for malaria. This is I advise. Prof. Tuti, thank you.
Yeah. Thank you. So I hope many doctors who join as a participant here would love to know about this, yeah, because then we will face the problem, yeah.
Yes.
Okay, thank you, Dr. Paulus. Thank you very much for your clarification.
I
Okay.
suffered from GERD, Prof. Dr. Paul, I took doxycycline and it was so suffering after 3 or 4 days. I cannot eat at all. Even swallowing my own sputum is not easy, you know. It was
Yeah,
just severe
you
GERD, and
experience with that, eh?
Dr. Tony said, "Well, just stop it, then you get malaria. It's fine." He said, "No, no, no, no."
Well, you can get malaria, Yandri, in
I
Papua.
went to Papua. The first time I went to Papua, I have to take my
Oh,
Dr.
you're
Tony
working in
asked
Papua.
me to take a doxycycline, and it was an effective way to lose my weight
Yeah.
because I cannot eat.
For example, myself, I went to Papua about 10 times, giving a lecture to anywhere from Timika to Sorong, Manokwari, Biak, and so on. But I never take a prophylaxis. Just prophylaxis, don't bite the mosquito. And yeah, lucky I never got malaria, or malaria is afraid with me.
Yeah.
Because you are the expert.
You, Dr. Paul.
Okay.
Okay, thank you, Dr. Paul. There is one more question in the chat. Sorry if this was previously mentioned by Prof. Haryanto. I want to ask if Plasmodium knowlesi is endemic in Indonesia.
Okay. Firstly, please do not mention I'm professor. I'm not professor. Dr. Yandri is forget I'm not professor. I'm all already for professor. About knowlesi. Knowlesi is already reported in Indonesia. Infected the human. It found in Aceh and North Sumatra. They already discover in the Makua mulata is a monkey there, and also in the human. But the diagnosis is quite difficult because the confirmation diagnosis should be used the PCR, and not all the places can have a PCR for knowlesi because the reagents is only limited, should be buying from outside, from Malaysia or from other places. So there is a knowlesi, but still a limited area in the mostly reported in Aceh and North Sumatra and some part of the Kalimantan. Okay, Dr. Widi?
Okay, Dr. Paul. Okay, here Dr. Pontap, raise hand and want to ask question.
Just ask you, Dr. Pontap from Thailand. Just ask
Yeah.
you.
Nice to see you, Dr.
Nice
Pontap.
to see you. Yeah. Nice to see you and to hear your talk as well. Since you talk about knowlesi, I just would like to know whether you can because the blood film is look like
Malaria.
malaria. Yeah, and
Yeah.
then have you seen any misdiagnosis or have you seen any severe cases?
Okay. So far, we are not having a cases with severe knowlesi so far, because our cases in Aceh and North Sumatra usually pick up by our surveillance. Yeah, during doing surveillance, usually mild malaria and very responding with because we are using the SP and they are already treated with the SP, but it's no problem. So far we are not having any cases with severe malaria because of knowlesi. Thank you, Dr. Pratap.
Thank you.
Okay, thank you, Dr. Paul and Dr. Pontap. Okay, because we are limited by time, I think this is the end of the 5th session of this webinar. Okay, I would like to thank you very much to Dr. Powell and Dr. Yandri and all of the participants joining this webinar. Okay, and for the other speakers that joining the discussion also. Okay, so for the conclusions, I can say that enteric fever and malaria is still a public health concern. but we actually can prevent the typhoid fever by vaccination, avoid suspicious foods and beverages, and practice hand hygiene. And for malaria, we can take chemoprophylaxis or take physical measures for avoiding mosquitoes bite. Okay. Again, I would like to thank you to the speakers, Dr. Paul and Dr. Yanri, for a very good presentation and very exciting discussion. Okay, I return it to the MC. Thank you.
Okay, thank you, Dr. Widi, who has led the fifth symposium today. And we also like to thank you very much to Dr. Paul and also Dr. Yanri for the very inspiring and exciting discussions today. And also for Prof. Tuti and Prof. Pontap, who also joined the discussions. So now we will start with, we will continue to our sixth symposium with topic traveling in special populations. For this symposium, the moderator is Dr. Putu Arya Suryandita, MSI. The academic background of Dr. Arya, he was graduated as medical doctor from the Faculty of Medicine, University of Udayana in 2012. He was also graduated as Master of Science in Medical Microbiology from the Faculty of Medicine in University of Erlangga in 2017. His current position is lecturer at Faculty of Medicine and Health Sciences, University of Warmadewa. His job experiences were internship physician at Sanjiwani Hospital and Payangan Public Health Center in Bali, Indonesia from 2012 to 2013, a general practitioner at Kiowai Medical Service in Bali, Indonesia from 2013 to 2014, general practitioner at Ubud Clinic, Bali, Indonesia from 2018 to 2019, and general practitioner at Viva Healthcare, Bali, Indonesia from 2010 to 2012. So Dr. Arya, the time is yours.
Thank you, Dr. Triani. Thank you for the opportunity to lead this symposium. And I will start this discussion with the introduction. Yeah, my name is Putu Arya from Travel Health Unit, Warmadewa University, Bali. I will be the moderator for this session. Yeah, first of all, I would like to welcome to all of the participants to this session, to sixth session of this symposium. And the topic will be traveling in special population. And in this session, we shall have three outstanding presentations from our prominent presenters, whom I believe will enrich our insight regarding specific population in travel medicine, especially pediatric traveler with diabetic mellitus, and also vulnerable traveler, which we will see during our practice in travel medicine. I also invite all participants to participate in this session, and you can write the question in Zoom chat panel. Before the presentation begin, allow me to introduce our first presenter. Our first presenter is Prof. Pontap Chantanavik. He is Associate Professor in Tropical Pediatric in Mahidol University. I will show his curriculum vitae first. Okay, Prof. Pontap Chantanavik currently is President of Thai Society of Travel Medicine and also Secretary General of Asian Society of Pediatric Infectious Disease and Treasurer in International Society of Tropical Pediatrics. His academic background, medical doctor from Siriraj Medical School, Mahidol University, DTMH in Bangkok, Magister Science MCH in London, DTCH in Liverpool, and also have a diploma Thai Board of Pediatric Infectious Disease and also Diploma Thai Board of Preventive Medicine in Travel Medicine. I want to welcome our first presenter, Prof. Ponter. Prof. Ponter will deliver a presentation entitled Major Problem of Pediatric Travelers. Please, Prof. Ponter, your presentation time is 20 minutes. You can start your presentation.
Thank you for the introduction. Let me share my slide. Can you see the slide?
Yes, Prof, it's clear.
Okay. Selamat pagi. Good morning.
Selamat pagi, Prof.
I would like to thank the organizing committee for inviting me to speak about these major problems of pediatric travelers. I will cover 4 topics. Travel with children, common health problems among pediatric travelers, and safety and also happy trip of children. As you know that now because of COVID, the number of tourists reduced a lot, maybe 1/4 to 1/6 of the previous one. This figure showed that the number of tourist arrival, the green one is 2019, the yellow one is 2018, and the blue one is 2019. The red one is 2021. You see, before COVID, the number of tourists is high, is up to 160 million per month. And the peak is during June to September. That is the summer time in the Western country. But and the total number of tourists per year is around 1.5 billion per year. But during COVID, you see in 2020, COVID start from January, and then it reduced a lot. You see, this is the whole world, this figure. But during summer, still some traveling. But in 2021, now still low. In Europe, there was still traveling during the summer time. But in Asia Pacific, in our region, in Thailand or in Indonesia, you see that it reduced, but now still down. No tourists come as usual. Also in North America, and Middle East and Africa. We in Thailand, because we have long lived with COVID, about 1 year and 8 months now. So we opened the tourist as Phuket Sandbox in 2021. Start in the 1st of July. But when we start before the opening, you see, we immunize the people in Phuket Island for more than 25%. We hope that they will get some herd immunity, even from the data variant, you see. And then in the 1st of August, we start another island in Samui. And 15th of August, we start what we call Phuket Sandbox 7+7. So we have another seal route in Phang Nga, Krabi, and Samui. And then after we start for 1 month, you see, after 1 month, we see around 14,000 foreign tourists arrive in July. Mostly from US, and second from UK, from Israel, and German, and French. And up to 14th of September, we have around 32,000 travelers. And then you see travelers coming to Phuket. We see that now it's changing the pattern of travelers. You see that they come with their family. You see children with their parents, also these children with their parents, or in group of close friends, not a big group, because they are afraid that maybe if they travel with some other that they don't know, some other people they don't know, they may get COVID, you see. Because even though those who vaccinated against COVID, they can have COVID with mild symptom or asymptomatic, but they can transmit the disease to the others. So that's why they come with the family or with their close friend and small group. And this many countries in Asia are also planning to open the tourist place for tourists. I think Bali is going to open very soon, and then Malaysia try to open the one island, you know, as a introduction to this tourist place to come, and then Cambodia may start to open Siem Reap for the tourists, and Singapore try to open to some country like China, Taiwan, Australia, New Zealand, and Brunei. But they postponed a little bit because of the last outbreak, last Saturday and Sunday, that they have around 1,000 cases on Saturday and Sunday. So you can see that traveling children are one of the members that traveling with their family. And so they have come because of leisure to relax, or come with friends and relatives to visit their relatives in and many travel because they are studying, they become students, or come to live in some countries more than 3 months as expatriates. But majority come accompany their parents, especially young children. Travel student is around 5 to 10% of international arrival. You can imagine it's quite a large number. It's a good time for the family to spending time together. They can have fun and play together, can learn the value, see the new places, see the world, and also development of the world views to expose to some other cultures and some other foods that they are not used to. And these travel children usually less likely to receive pre-travel advice, not like adult. Adult usually have pre-travel advice, especially those who are backpacker. We notice that backpacker, they are majority are young people, are teenagers. They receive most of the pre-travel advice. And if the pediatric children ill, they are more likely to be inpatient care, more likely, more than adult. The most common health problems among children. The first one, diarrhea. This is the same in adult and everywhere, you know. Travel diarrhea is the most common problem in travelers, even in children. The second one is about dermatological conditions, like exposed to animal bites, rabies, quite common in our region in Thailand and also I think also in Indonesia. And then cutaneous lava migrant. You see this picture? Can you make the spot diagnosis? This is a sanguineous eruption with very itchy on the feet. So this is creeping eruption from animal hookworm, from dog and cat hookworm, that the child or travelers can get it when they walk barefoot on the sand or sitting on the sand, lie down on the sand, that have contaminated with feces of dogs or cats, and then the hookworm penetrate their skin and got this creeping eruption. And sunburn, the children are more prone to sunburn than adults. Other systemic illness, also febrile illness, also quite common in children. You see this picture? Can you make the diagnosis? This is a fever for 3 days and rash, but rash is fainted or branch when you compress it, when you press it, it branch. So this is dengue fever. This is quite typical if you see this. And children can have respiratory disorder. Another very important thing is accident. The most common accident in children and also in adults as well is motor vehicle and water-related injuries, because children like to swim. So this figure is the common disease occur in adult. You see majority is gastrointestinal and mainly diarrhea, whether either acute diarrhea or chronic diarrhea. And the second one is febrile illness, dermatologic condition, and respiratory infection. These are common in adult. In children, if compared to adult, children have more or less the same disease as adult when they travel to the same destination. But illness in children usually present within 7 days after return. If they return to their hometown, usually present within 7 days and require hospitalization that I mentioned before. Lack of pre-travel advice usually, and mostly visiting friends and relatives. Yeah, I think you listened to the talk before that. Visiting friends and relatives are more prone to illness or disease because they come to stay with their friends or family in another environment, another destination. They are not used to. They getting to eat the new kinds of food and exposed to different water and foodborne diseases which they are not accustomed to. So they are more to get the disease than other group of people. This study compare the disease found in adult and children. This is done by Geo Sentinel. Geo Sentinel is a travel clinic around the world. They collect the data, and this data collect in Asia, Sub-Saharan Africa, and Latin America. So you can see if On this side is more to get the disease in children. On the right side, you can see the diarrhea, acute diarrhea, and especially the bacterial diarrhea and acute gastroenteritis are more common than adult, are more common in children than adult. The dermatologic disorder also are more common in children. Animal bites more common in children because children like to play with animals. They love to dogs and cats and sometimes monkeys as well nowadays. I think Bali have the place that you have monkeys, a lot of monkeys. So children like to play with these dogs and monkeys and also other kinds of animals. Cutaneous lava migraine also common, more common in children, and respiratory tract infection also more common in children. But you have to notice that children have their own disease and they are more prone to upper respiratory tract infection anyway. This is by age. If we see by age group, you can see this purple is bar is 0 to 5 years, blue bar is 6 to 11 years, and the gray bar is 12 to 17 years. You see that acute diarrhea more common in under 5, under 11 years old. And the dermatological condition are more common also in under 11 years old. Febrile illness more common in 12 to 17 years old. Malaria more common in under 5 years. And then respiratory disorder are more common in under 5. This is another study from Israel. Only in Israel, children going to South Asia, Sub-Saharan Africa, Latin America. You see that gastrointestinal diseases more common in 6 to 12 years, and the fever more common in under 5 years. Dermatological condition the same, but more common in over 13 years. And they have schistosome in over 6 years old. I think at least Israel children like to swim in the freshwater canal or river that have schistosome. So they got schistosomiasis. If you see the child diagnosed by region of the place of destination, you can see diarrhea, the green one, more common in the Middle East and North Africa. Dermatological problem more common in Latin America, and systemic febrile illness more common in Sub-Saharan Africa. This mainly because of malaria, because Sub-Saharan Africa malaria is endemic there. But second one is Asia. Second Asia, the most common is dengue fever. We have malaria, but less common than in Africa, So fever in children or even in adult travel to Asia, mainly majority are dengue. And then respiratory disorder in more common in Europe, maybe because of the cold weather. As you see this picture, what is your diagnosis in this picture? This is the blood film with ring form and double Here, chromatin, double chromatin, and then many in one parasite multi ring form. This is for example malaria. And the upper one, this is the fever for 3 to 4 days, and then you have to negate test positive. This is dengue fever.
20
And
minutes left
mode
for
of
the
transmission
presentation, Prof.
of the disease of children, mainly, you see, is foodborne. So foodborne is very important for travelers, both adult and children, and then they can have diarrhea, and also the one just mentioned, salmonella or other foodborne diseases. And then second one is animal bite and sting. And then third is a mosquito-borne disease, freshwater contact, and also tick-borne. This picture is a tick-borne. Have this typical pathognomonic signs. This is ESCA in scrub typhus. You can see also rash. Yeah. So when you travel with children, and you know that children can get those illness or common diseases and common problem like accident as well. So you have to know, to learn about the activities at the destination. What children like and what children dislikes. Children likes animal, every kind of animals except if they afraid it. Like crocodile, maybe children afraid of crocodile, but other it's all right for children. They like action, entertainment, or change of horizons, and like to be with the family cohesiveness. Stay with the family, enjoy the family, uh, and they like to do things to be memories and to have the story to tell their friends. You see, travelers when they come to the country, any destination, they don't they see the elephant. They don't just look at the elephant or take a picture with the elephant, but they have to be on the elephant like this, you know. Why, like we when we go to Egypt, we have to be on the camel, or else we don't go to Egypt. Like it's the same for travelers, you know. They have to do everything and not just take the picture. To be in the uh, to be the in the atmosphere of traveling, not only see the video, you see. So children doesn't like children don't like very long flights or too hot and too cold, very extreme temperature. Children doesn't like. Children don't like uh, illness resulting from poor sanitation, especially diarrhea, or severe vomiting, food poisoning. They don't like. Uh, then they don't like injection. They don't want to take the vaccine. Any children, even some adults also afraid to take the vaccine. You can see when we mass immunize COVID vaccine, many uh, uh, people, even the nurses and the doctors, are so afraid of the injection that we learn that not only the children that afraid of the injection, but also adult, even the doctor and nurses afraid of this. So we know that the children illness and children activities. So now we have to try to know what we should consider when we see children, and when the children come to see you and ask for your consultation when they want to travel to some destination. First, the most important thing is to be sure that they will have a safety and comfort, also a happy trip, not just prevention of the disease. But the most common in children is safety, happy, and comfort trip. And the second one is about prevention, especially immunization, and avoidance, how advise them how to avoid insect-borne disease like malaria or dengue, like the previous talk also mentioned about this. And children, you know, that have numerous routine illness, so you need to prepare something for children. The thing that you should prepare is a medical kit, a bag with some medication, which I will talk in my last slide. And then diarrhea prevention and management, the food and waterborne disease prevention, sanitation is very important because children doesn't like diarrhea, you know. And diarrhea will make their trip more difficult, or even sometimes have to stay in a hotel or stay at home because they cannot go out. 2 weeks to go out. And then children are more vulnerable to severe sunburns, so prepare some sun protection for them. The children have varied activity. This according to their age. The older age, they may like to go to the fun park, you know, like adventure tour for the older age. But the younger age, they may like to swim. So different age have different activities. You have to know that. So in our pre-interview advice, general rule is you learned before from yesterday, and also some in today talk, that you need to take to talk to them about the traveling, the destination, and then the risk assessment for that destination, and also the risk of traveling also. So ask about destination, activities, underlying disease, then you can advise them what disease common, what condition should be avoid, and then whether they need immunization or chemoprophylaxis. So it's up to them to explain them about the risk. Some may think that they can avoid the risk of salmonella or typhoid fever by food and waterborne precaution, good sanitation. So they may not want to take the vaccine. It's just it's their choice, you see, but we will explain them the risk. Then getting prepared for the vehicles, for the plane, the vehicles, the vehicles for children, if they travel by car, they need a special seat for young children. You see, like this. And at the destination, very important because accident is common in children. So accident prevention when traveling, and then when enjoy swimming, they have to prevent the accident. Frequent rest stop. If travel don't have a very long trip, because children that's a long trip. Yeah, but frequent rest stop and prepare and have plenty of food and hydration, food and water, plenty of food and water for children. And general preventive measure, all of you know about it. And one very important is travel kit. The one that you have to know when travel with children to keep them happy and busy sometimes. So plan to keep them interest or busy to do something, like give them some camera, so encourage them to observe. But nowadays we have mobile phone, so you have games on the phone, so it's quite easy for look after the children. And then suggest the diary card for the diary for them to make note memories, and then they can tell this memory story about their journey to their friend, you know, and bring many toys and puzzles and drawing pad, books and family games for them to do. And one, if you can do, is a child monitor or tracking device to tag in place of busy places like Disneyland or shopping malls or airport. You can track the child if they get lost. My last slide is about the medical kit for traveling children. So prepare this if you travel with children. There are about 4 parts in this medical kits. First is identification, name, date of birth with allergies to any drug or any insect or animals, immunization history, current medicine, blood, blood group, blood type, and then first aid treatment, like bandage, tape, alcohol, or iodine, okay? And medicine, I think this is up to you, but I would suggest first is antibacterial skin ointment, Bactroban, uh, antibiotics ointment, a steroid cream, antihistamine, motion sickness preventive drug, acetaminophen or ibuprofen. Then preventive treatment for travel dyslexia or anti-malaria. But this one, I think if you have to give this to the parents, you have to tell them in details when to use. And then oral reagent solution, insect repellent, and sunscreen. So the very important for children. And also in adults, I myself always carry this medical kit when I travel. That is my last slide. Thank you very much.
Thank you, Prof, for great insight
I
about
finished my presentation. Yeah.
Okay, thank you, Prof.
Any question, or you will do it in the last section?
We'll do it after the other presenters, Prof.
Okay.
Thank you, Prof.
Thank you.
Thank you for the great insight about problem in pediatric travelers, Prof. And now I will introduce our second presenter. Our second presenter is Prof. Swastika, internal medicine specialist and consultant in endocrinology. I will share his curriculum vitae first. Prof. Swastika, he is currently head division of endocrinology and metabolism, Department of Internal Medicine, Faculty of Medicine, Udayana University. He also guest professor at Kobe Women University and also president of Indonesian Society of Endocrinology. He holds medical doctor, internal medicine specialist, especially consultant in endocrinology, PhD, and also professor in medicine. Please, Prof. Swastika, present the presentation, which entitled Diabetes mellitus and traveler, any specific preparation. The presentation time is 20 minutes, Prof, and you can start your presentation.
Fine, Mr. Chairman, thank you very much. Could you hear my voice?
Prof, it's clear, Prof.
Okay, fine. I will share my slide first. Yeah, in this occasion, I would like to express our gratitude and thanks and appreciation to the organizing committee to invite me in the very prestigious meeting. And of course, also our colleagues, Mr. Dean, and also Mr. Rector of the Faculty of Medicine and Health Science, Warmadewa University, and all our colleagues in that university. In this moment, I would like to talk about the diabetes mellitus and travels based on request from the organizing committee. And I will start my presentations. I'm sorry. on the epidemiology of the diabetes in the world, I think diabetes is still to be health problem in the world, not only in the developed country, but also in recently, maybe more dominant in the developing country. And then looking the atlas, the latest atlas from the IDF, that the increasing number of the people with diabetes predominantly in the African country, for instance, and also in the Middle East. But Indonesia, anyhow, Indonesia also one of the country who having that huge number of patients with diabetes, and then including also the biggest 10 country who have a huge number of patients with diabetes, especially in adults. Okay. Okay, sorry. We also talking about the percentage or the number of the patients with diabetes in the adults, talking the 10 biggest countries. Yeah, the biggest country who have the most absolute number of diabetes in the world. Indonesia is to become number 7. Yeah, especially in the population, in that population between 20 and over. Yeah. And we can see that in adults, 1 out of 11 people having diabetes. You can imagine that if a part of the people will travel around the world, you can count by yourself. One of you can see 1 of the 10 people or 11 people having diabetes, I think maybe with its problem with its diabetes. For instance, in Bali, before a COVID pandemic, in Bali, around 3 to 4 million people, especially foreigners, come to Bali or visit Bali, and then more than 10 million local tourists, local people also visit Bali. You can calculate the patient, how many people with diabetes will visit Bali, only Bali, but you can imagine around the world. Okay, fine. But the next question is, need the people with diabetes afraid to go traveling in the world? I think no reason. Jadi no reason can't enjoy seeing or traveling in the world for patient with diabetes. I think anything can prepare, anything can be treated well, and then can enjoy, can traveling anywhere in the world for patient with diabetes. I think no any barrier, no any handicap for the patient with diabetes traveling in the world. The most important, some key point should be a concern for patient with diabetes. The first is patient should be packed all diabetes medications and supplies in the carry-on bag and keep it their position at all time. I think very important to prepare the medication who need the patient during, or I think depend on the how long the patient will traveling outside. And a travel letter will facilitate easy transfer through the security and custom. It is very important to show that what you will be bring, what equipment, what medicine should be shown in the security in the airport, because will be maybe sometime will be checked by the custom in the airport. Patients should always take more supplies and needed to accommodate changes in the travel plan. Yeah, I think a very important one, because maybe your plan will go to traveling for a few days, but actually maybe more day will be extended, yeah, for traveling. So need more medicine, more anything related to your need for diabetic, your diabetes, for instance, like glucometers, stick, I think should be more supply for that purpose. And a patient will cross multiple times soon, especially traveling from your country to more than 5 hours, yeah, different zones. I think maybe a need adjustment of the dose, and then adjustment of your medication, and also adjustment of your food. Okay, what can prepare in the pre-trip? Provide a patient before travel, checking the basis. Healthcare providers might be need immunizations, and also depending on the region travels, prescribing maybe antibiotic, because the patient with diabetes are vulnerable to get infections, or maybe antidiarrheal in case you going to the endemic area for the diarrhea, for instance. Yeah, and then packing with diabetes double is better. I think more needs a plan for your staying in the purpose area. Encourage patient to create the checklist of diabetes supplies and medication needed for the duration of the trips. And patient with diabetes should choose his comfort over style when selecting footwear. Yeah, it is very important. You know that the patient with diabetes, once again, vulnerable to get the diabetic foods, and then maybe laceration, and then should be used the comfortable footwear. Emergency abroad, planning to be prepared. Encourage the patient with diabetes, especially those who use insulin. I think maybe once time need emergency room or emergency, because insulin also related to the severity of the diabetes, and insulin also very frequent related to the hypoglycemia. Maybe one time needs clinic, yeah, or emergency related to the hypoglycemia, for instance. Okay. And then it is only example that example of the travel letter, yeah, from the doctor or from physician or from your the diabetic patients family medicines, and then should be states that what kind of the diseases, and then what kind of the medication, and also what kind of the equipment should be bring during enter the custom, especially in the iPods. Yeah. Okay, and then we also are talking should be remind about the checklist, yeah, for patient with diabetes, especially concern about the medications. Yeah, if the patient use insulin, should be pack extra syringes or pens, needles also, and also oral medication pack, prescription in the clear and easily accessible safer reclusable plastic bag. And then should be remember that blood testing supplies, yeah, glucometer, strips, and alcohol swab, and also a tablet for in case you have a hypoglycemia during traveling, prepare glucagon injection, or maybe a tablet, glucose tablets, and sometimes also need, in case of you have other complication, for instance, like the gastric problems, you should be prepared the anti-nausea or maybe antibiotic in case of you have vulnerable for your food, yeah, the patient food. Fine. And what should be concerned in the airports, yeah, during travels? Yeah, airport security. Once more, I hope you the patient should be bring the traveler letter from the doctors about the all related your illness, your diabetes, yeah, and then storing diabetes medication well, insulin also, insulin as in the, yeah, you know that insulin in the room temperature, I think doesn't matter to keep for 20 hours. And then for infant in for 1 month, yeah, I mean. And then remember that you will traveling across the time zone, wide time zone, or only short-term travelings. And adjusting should be insulin therapy. I think depend on the what kind of take food during travelings, and also depend on the duration of the flying. For instance, in the flights. And also prevent of the venous thromboembolisms in the air travelers. I think maybe in case of your flight too long, I think maybe you can exercise in the flight, yeah, not only staying in the chair, for instance. Fine. And remember during the flight, time zones and also insulin dosing. I think maybe I will explain in a brief in the later on. Yeah, you will go to the you will travel in the westward or in the eastward, because it is a quite difference in case of you of the patients, yeah, traveling to the eastward. I think maybe the time a little bit like shorter, but in if go to westward, I think maybe the time look like more than 24 hours. And then should be calculated, especially the patient using insulins. Advice for patient on oral diabetic medication, I think maybe also sometime maybe needs skip the medication, because a little bit hyperglycemia might be much better than hypoglycemia during traveling, especially during in the flights. Insulin should be storing, yeah, in the flights, yeah, and then also until landing in the purpose of the objects countries, yeah. Insulin actually can be keep only in the room, yeah, room temperature for 1 month, but in case you traveling more than 1 month, you should be have a special case, should be a special keep for the insulin in the less than for around 4 centigrade to prevent the insulin couldn't use for because one insulin in the pen, or maybe in the vials, maybe will be the effects, yeah, the efficacy will be to be less in case of more than 1 month in the room temperature. And then don't forget then food, drinks should be adjusted, because sometimes some food or drink may be quite different between the original country than the purpose objects country and new countries. And then don't forget also physical activity to keep your blood glucose levels well. And then once more, I think also very important to keep hydration, because in one country maybe too hot and too high humidity, and then maybe the induce the patient will be dehydration, and then so the enough or sufficient drinking of especially water drinking, as is very important for the patient to keep the hydration. And also, you know, that dehydration can induce the hyperglycemia for the patient with diabetes. And then we are talking about the adjustment of dose of the some medication, both orally or insulins. In generals, I think the most concern of the patient with diabetes is hypoglycemia. So in case of the medication, both oral or insulin can induce hypoglycemia, especially sulfonylurea, should be skipped in case, especially in case of the patient traveling eastwards. Maybe if you use the sulfonylurea twice a day, I think maybe the second medication should be skipped, or metformin also can be skipped in the second tablet in case of the immediate release. But in case of use sulfonylurea once a day, I think the dose should be reduced for the patient who traveling to the eastward. But in case of traveling in the westward, I think maybe no adjustment for those medication. And also, I think the glycine is very similar with sulfonylurea. I think very similar. And then should be only adjusted in case of the travel to the eastwards. And how about the TZT, AGI, and DPP-4 inhibitors and GLT2 inhibitors? I think all the medication almost very a few or maybe very low to induce hypoglycemia. And in general, all of medication maybe without adjustment for the dose, except in SGLT2 inhibitors, sometimes can induce the hydration. You should be carefully, especially if go to the country who has very hot and also has humidity too high. A GLP-1 receptor agonist also, I think, relatively no has an effect of the hypoglycemia. I think we can see no any adjustment of the dose and also amylin. But insulin is very important for concern both patients with type 1 and also type 2 diabetes. Talking about the prandial insulin, I think maybe prandial insulin we only use in case of the patient of the travelers taking the food. I think maybe should be adjusted the prandial insulin based on the food intake of the patient. But how about the insulin, basal insulin? Yeah, I think basal insulin, I think maybe more important to adjust it because basal insulin can be divided to be two kinds. Yeah, basal insulin twice a day, for instance, like NPH, and so a newest basal insulin almost injected only once a day. In case of using the NPH, yeah. In case of using the NPH or intermediate acting insulin, I think maybe the latest injection, the second injection maybe can be stopped. Yeah. In case of the patient travel to eastwards, but maybe not in the travel to the westwards. Yeah, but in case of you use the basal insulin long acting, I say newest basal insulin, I think only need adjusted of the dose. Yeah, adjusted of the dose, especially the patient who travel to the eastward, I think maybe can be reduced 10 or 20% of the initial dose, but no any adjustment if they travel to the westward. Using the premix, I think very similar with the basal insulins. Yeah, basal insulin twice a day. I think maybe the second premix dose should be reduce the dose, or maybe much better switching from premix to be basal bolus injection. Okay, I think maybe I have already talked about the insulin, prandial insulin. Now, sometimes I have also in Bali have the foreigner with the type 1 diabetes using the insulin pump. You should be, I think the patient should be care about the insulin pump. Should be, I mean that sometimes pump maybe not work well in the very hot and very humid weather. So the patient should be ensured that insulin pump can work well. Okay, what can I summarize? Okay, fine. I think this one is the last slide. What can I summarize about the patient with diabetes? He would like to traveling in the other countries. Yeah, the first is should be pack offer or the medication, because sometimes maybe the patient need a longer time. Yeah, maybe changing the planning of the the travelings, and then protect the supplies, yeah, both medication and also the equipment, including glucometers on something related to the diabetics. And then identify yourself, yeah, remember traveling letters, and then maybe important, especially in the custom, yeah, and carry snacks, yeah, or tablet in case of the patient have too low blood glucose levels, uh, and simplify applying test often. Test of blood glucose level I think more often, because sometimes maybe having hypo and then hyper. I think depend on the food intake, depend on the medication, depend on the weather or season of the country, which the objective for the patient travelings. And then also very important to concern about the feed, because the patient with diabetes, the feed or food are very vulnerable to get infections. Yeah, and then don't remember use the comfortable footwear, yeah, shoes. I think very important to prevent the laceration, prevent the infections, and then prepare for a healthy emergency, because once time patient with diabetes maybe have a hypo or maybe getting infection or anything related to emergency. I think that's my presentation. Thank you very much for your attention.
Thank you, Prof, for great presentation about a diabetic problem in traveler and how to adjust the therapy for the travelers. We will have a discussion in the later part of this meeting, Prof. And now I will introduce our last speaker for this session. And the presenter is Professor Tuti Parwati Merati, internal medicine specialist and consultant in tropical and infectious disease. I will share her curriculum vitae. Prof. Tuti currently is Head of Tropical and Infectious Disease Division in Faculty of Medicine, Udayana University. She holds medical doctor from Faculty of Medicine, Udayana University, internal medicine specialist from Faculty of Medicine, Airlangga University. She also consultant of tropical and infectious disease, and hold PhD from Udayana University. She already published a lot of publication, especially in tropical disease and infectious disease, especially HIV disease. Please, Prof. Tuti, you have 20 minutes for presentation. Time is yours, Prof.
Yeah, thank you, moderator, Dr. Arya.
Yes.
How about my voice? Can you hear me?
Yes, I can hear you, Prof.
Okay, thank you. So first of all, I want to thank the organizing committee to invite me to join in this very important webinar. Yeah, and also I would like to say thank you to the Dean of the Faculty of the Warmadewa Hospital, Dr. Anom Murdana, yeah, because he's write the letter of invitation. And also I would like to grade the participant, which is still here, I hope. Yeah, the topic I would like to speak this morning is about an update in vulnerable traveler. Please, I would like to the committee to share my screen. Yeah, okay. So vulnerable travelers, an update. Yeah. Slide, please. Next slide, please. by the time. So we have two already great presentation about diabetes in travel and also traveling with children. So it's all the two topic is also involved in the vulnerable group of people. Yeah. So as we know that COVID-19 pandemic impact health and economic crisis as on a globe scale, yeah, and international tourism is among the economic sector most impacted, yeah, by the COVID-19 pandemic, yeah, and the uncertainty of the pandemic situation would influence countries' regulation for travel and travelers, resulted in frequent changes of the regulation based on the country's pandemic situation. So maybe this is one important that we have to consider, yeah, in this pandemic era, yeah. And vulnerable travel, especially are people who would be at increased risk for severe illness affected by the traveling, especially in this pandemic era. Yeah, and in the context of traveling, vulnerable travel should be given better preparation. Yeah, like the one that we already heard. How about children and diabetic patients to prevent and minimize the impact of the travel? Next slide, please. Oh, this is very interesting travel regulation map. Yeah, in the left side is on November the 2020, and on the right side is on September 2021. So we see here that countries or area with totally restrictive regulation is decreasing. Yeah. Now less country implement totally restrictive, and also if we see the area with not restrictive is less also, yeah, compared to the November. This area is not restrictive, so it's liberal regulation. But now we have seen here Latin America is more prepared to the pandemic, and more partially restrictive area now we see. So what is interesting for this travel regulation map is we can see, we learn from the pandemic, which is now in the second year. Yeah, we learn very much how to adapt, how to live with the COVID-19. So we hope that by the time we can learn and tourism will be recovered the next year. Yeah. Next slide, please. This is just a COVID-19 situation in Indonesia. So we have more than 4 million confirmed cases with 140 and 805 death case. Yeah, but the cure rate or the recovery is high. Yeah, very high. So also about the vaccination, the first vaccination is about 80 million people, and the second vaccination or full vaccination is about more than 40 million cases. Next slide, please. This is the group that we would like to discuss. Yeah, especially in the pandemic era. So even in the non-pandemic, we have to be careful for this group. Yeah, because this group of traveler will become affected by more serious disease. Yeah, so here is senior travelers, pregnant women, immune compromised, disabled infant and children, and chronic disease or pre-existing medical condition. Next slide, please. we talk about the senior travelers. The senior citizen are grouping as this category, yeah. Early retired or young senior, which is involve 55 to 64 years old. And then 65 to 70 years is retired group. And then mature senior and 85 years plus is older senior. So this senior category has a characteristic of I would like to ask your opinion too, is availability and flexibility of time, yeah, increased need of health services, I agree with this, a fewer obligation in life, and interest in culture and tradition. So this is the characteristic of the older seniors, yeah, which will be involved how they travel and where they go and what they want to see when they are traveling, yeah. Next slide, please. And this is the travel-associated illness in older adults. So the profile of diagnosis for travelers aged 60 years and over versus travelers ages 18 to 45 years. So it looks like there are more, this is about all the infectious disease, yeah. And lower respiratory tract is increasing, and also the HAPI, and also the injury, trauma and injury is also increasing in this group of older adult or older seniors, yeah. Next slide, please. And this is the age dependent of selected travel associated disease. We can see the darker the purple color is the Plasmodium falciparum malaria, and then lower respiratory tract infection, heart disease, and death. Yeah, among the younger, I call it the younger, the adult. Yeah, it's more for Plasmodium falciparum malaria or malaria in general, and less in older senior, yeah, but more heart disease and lower respiratory tract here we can see in this older senior, and also the death among the older the seniors is more in this group. Next slide, please. And this is the COVID-19 hospitalization and death by age, yeah. As a comparison group, they take, this is from the CDC, coronavirus, yeah. On the age 18 to 29 years as a comparison, we see that by age, the hospitalization need is lower among the younger, yeah, lowers, yeah. Lowest in the balita and less than 4 years, but more in the young adults, yeah. In adolescent, maybe it's 9 times, but by the time ages is increasing, the hospitalization need is 8 times or 5 times higher, yeah. How about the death? The death also for comparing to the comparison group, the older, the senior is higher, very much higher, yeah. We can see here 90 times or 220 higher, yeah. And up to now, we still, for all the group, action to reduce risk of COVID-19 is still prevention is the better. Wearing a mask, social distancing, and hand hygiene, and cleaning and disinfect the surfaces. Yeah. Next slide, please. So this is just like a summary if we travel with elderly, just to summarize. So vaccination is available. So COVID-19, whatever is the availability of the COVID-19 vaccine. So every vaccine has their a note, yeah, something like AstraZeneca vaccine that with the side effect of thromboembolism. So it's prefer in the olders, yeah, compared to the youngers, yeah, and make sure that any comorbidity is under control. Something like the elderly with diabetic. Prof. Swastika already inform us very detailed, and to visit a doctor and get medical clearance to travel, and the itinerary where they going to do in the destination has to choose uncrowded places, minimize going outside, and meeting with a large amount of people. So we avoid that overcrowded. Yeah. Next slide, please. And how about pregnant travelers? Yeah. Pregnant travelers, next slide. We can see here the admission of pregnant women with symptomatic confirmed COVID-19 to UK hospitals during the time, yeah. This is the green one is during the wild type pandemic. And then the blue color is with alpha variant, very high here. And also this is just only in 2 months for the Delta variants, an orange color here. So it we don't know next by the more time we follow, maybe we can see increasing of the pregnant woman affected by SARS-CoV-2 infection. Next slide, please. So for pregnant women, the best time to travel at gestational age 14 to 28. So what is the best time? This is the safer time. And if we travel after 28 weeks of the pregnancy, should be limited to only less than 100 miles radius, yeah, and not recommended if the pregnancy have a complication, something like preeclampsia, pre-labor rupture, preterm labor, something like that. Avoid the outbreak of Zika area, malaria endemic area, if still possible, yeah. And fully immunize the woman, yeah, and except for live virus vaccine, yeah, but excluding yellow fever if they have to go to that area. And reduce the deep vein thrombosis rate, yeah, some with the sufficient fluid, loose fitting clothing, and walk and stretch at regular interval if you travel on the aircraft, something like that. So next slide, please. Next slide. Yeah. We good to educate the woman to know the alarm sign, yeah, and maybe the important to seek emergency medical service if there is a vaginal bleeding, pelvic or abdominal pain, yeah, or contraction or rupture of the membranes, of course, sign and symptom of preeclampsia like headache and seeing spot. Or other changes in eyesight and swelling of the face or hands, and then severe vomiting or diarrhea and signs of DVT. So we have to educate the woman when they are preparing for travel. Next slide, please. Infant and children travelers. So we have a lot information from Prof. Pontep, yeah, already. But this is just the coronavirus case fatality rates by age, yeah. This is come from South Korea, Spain, China, and Italy data. And we see here there is no death less in age 0 to 9 years, yeah. But then there is a very rare death rate in less than 19 years old, yeah. But then we, by the older ages, we see here the almost 20% of the case fatality rates, yeah. But there is two main limitation to keep in mind if we interpret this kind of CFR draft, yeah. The first is many cases within the population are unconfirmed, yeah, due to lack of testing, unconfirmed cases. And then some individual, maybe they are already infected, but during the recording of the data, they are still alive, yeah. Eventually they maybe will die, yeah. Next slide, please. And this is okay, this is about already mentioned travel destination. People from Asia or going to Asia is more travel, yeah. And we see the changes of pattern of tourism in the era of pandemic, yeah, like Prof. Pontep already mentioned. Now more family members and small group of travelers now, yeah, compared to before. Next slide, please. I think this is the same slide already mentioned by Prof. Pontep. And yeah, we just want to note that in Africa it's malaria, and here is more febrile illness, and here in Asia more maybe dengue, yeah. But diarrhea disorder is in the Middle East and North America. It's very clear from this slide. Next slide, please. Then this, if we travel with children, can I just to skip this because Prof. Pontep is already mentioned a lot of this, yeah. So the most important is to advise them to consult a travel health practitioner at least 6 to 8 weeks in advance of departure. So Prof. Pontep already mentioned that children usually less with pre-travel advice. So now the family members should bring them to this department. So best time to travel and age limit for most airlines usually in the babies is after more than a week old. They can they just allowed to fly, yeah. And the risk of to health vary among the children depending on destination, length of stay, plan of activities, and general health and of the children, yeah. This is already mentioned by Prof. Pontep. Next slide, please. How with chronic illness, travel with chronic illness. Next slide. So this is the major pre-existing medical condition among travelers with chronic disease. So diabetic, so endocrine or metabolic disorder is the most, 38% we found, and cardiovascular and pulmonary. So diabetes, cardiovascular, pulmonary illness is among the three most frequent seen among travelers with chronic illness. Next slide, please. And these people, a list of these people is are a group of high risk of corona virus disease. Yeah, so that's why we have to be careful. So this the disease itself is already vulnerable for them to travel, but adding in now at the pandemic era, it's there is a more serious problem again with the respiratory or infectious disease, which is transmitted human to human, yeah, with the respiratory. Next slide, please. And this is especially this existing condition, serious ailment, death, percentage of death is cardiovascular. Yeah, so if we can summary we can see the summary from of the Professor Pontap presentation, the children affected by diarrhea, and especially for also adult, not just for children. So diarrhea is the most frequent, but the cause of death is mostly from cardiovascular disease. Yeah, and this is usually among the patient with chronic disease. Yeah, and then followed by diabetes, chronic respiratory disease, abnormal high blood pressure, cancer, and no existing condition. Yeah, maybe they don't die with the disease, but maybe from other disease. Next slide, please.
3 minutes left, Prof.
3 minutes. Okay, thank you. And this is the indication for cardiovascular oxygen supplementation during the commercial flight. So individual who require oxygen supplementation at baseline, and then class 3 to 4 of the congestive heart failure by New York Heart Association, or PO2 less than 70 milligram mercury, and then angina, class 3 to 4, cyanotic congenital heart disease, primary pulmonary hypertension, and other cardiovascular with hypoxia. This is an indication for oxygen supplementation during commercial flight. So next slide, please. And this, I think, the contraindication related to cardiovascular problem. So this is the list. So post-acute coronary syndrome, so they don't they are contraindicated. Unstable angina, decompensated heart failure, uncontrolled hypertension, and coronary artery bypass less within 14 days, CVA within 14 days. So this is all the disease that contraindicated with commercial flight. Next slide, please. Oh, yeah, and about respiratory condition, we need to do a spatial assessment, history of previous intolerance, COPD, severe bullous lung disease, and severe lung restriction with vital capacity less than 1 liter. So all these disease need spatial assessment when they in the pre-travel consultation. Yeah, next slide. And this is the contraindication of commercial flight in respiratory disease. So if then from assessment we found this list of disease, so they are contraindicated for commercial flight in respiratory disease. Next slide, please. And malignancy also related contraindication for travel with commercial flight, because there is other than malignancy itself, the treatment also anemia, oxygen dependent, high risk brain edema, within 6 weeks or less, post-cranial surgery, malignancies with complication or comorbidity. So all these are contraindicated for traveling with commercial flight. Next slide, please. And now we will now learn about air travel in the pandemic. So the quality of air on board aircraft, they said that is carefully controlled, change very frequently, and pass through efficient at removing virus. So don't worry about the flight, in-flight quality of air. So, and IATA state that millions of flights since the start of pandemic and no cases of in-flight transmission. Yeah, they describe risk of in-flight is as very low, provided, but you have to provide a mask worn in flight, yeah, and also maybe self-distancing, yeah, and extra layer protection, yeah, and this is regulation to follow, yeah. Don't travel if you are unwell, yeah. You will be exit screening, maybe implemented to you, and you will be denied on boarding. And continue to take good hygiene measures, yeah. Avoid moving from your seat unnecessary, yeah. But continue to exercise your legs, yeah, on your chair. If you are unwell, stay in the seat and follow any instruction provided during the flight. Next slide, please. And this is advice. I think the more before then, yeah, yeah. This is for how to prevent the spread of respiratory viruses. Yeah, I think this is all we know about this, but should be implemented carefully or strictly. Yeah. Okay, next slide, please. This is when we travel with disabled person, vaccination, sanitize, or the disabilities assistant tool, and then choose uncrowded places, visit the doctor before, avoid as much as possible, but help by unknown person, yeah. Bring your own or need assistant if you need. Okay, next slide, please. This is maybe before this, we have the last recommendation. Before this, there are one slide, yeah, from WHO. You have to follow that, and also this one, yeah. This is the very routine prevention to us to implement, yeah. A slide, next slide. If you still decided to travel, then some recommendation. Next slide, please. General recommendation, yeah. The general is about vaccination, and if develop symptoms, so don't travel, yeah. And this is all the hygiene and protection against the respiratory virus transmission. Next slide. And specific recommendation is, yeah, people with chronic condition must carry extra medication, yeah, maybe 2 or more, double the stock, yeah. And then people with obesity and other chronic disease must have insurance that cover COVID-19 in destination countries. So insurance is important. And then wear the mask, FFP2 or FFP3 masker, and pregnant women should have pre-travel consultation and clearance from the OBGYN doctors. Next slide. This is because of the uncertainty, yeah. What we do with the vulnerable traveler, usually because the air travel by aeroplane is a bit dangerous to them, so they will choose the cruise. But now with the pandemic of COVID-19, this is also the CDC regulation to the cruises, yeah. The reason why they avoid, they make this regulation is because the coronavirus disease spread very easily in close quarter aboard ship, yeah, and the chance of getting COVID-19 infection is very high on the ship, yeah. And also they has this regulation, all cruises passenger be fully vaccinated and implemented indoor masks. So you can imagine how you in your room or in your public shares should use the mask over time while you are taking leisure with your cruise. Yeah, so that's just an illustration, but this is because the changes. We will see what will happen in the next year. How can we deal with the adaptation to this COVID pandemic? I think that is the last slide, maybe. This is a regulation, update regulation. So always changes also for Indonesia, for Bali, for Jakarta, for other people like Bangkok, something like that. Next, maybe this is the last slide, take home message. So in the COVID-19 pandemic, preparation for travel changed a lot, yeah. As the pandemic changed our life, yeah. Minimize traveling as much as possible. And only when necessity is higher than the risk, travel with precaution, yeah. And always practice good COVID-19 health protocols, wearing mask, sanitizing hands, and cough etiquette, and adopt special precaution if you are categorized as vulnerable travelers. So should have the travel clinic advice, and issues considered strictly is to see the travel advice. The itinerary maybe changes because of your condition. Travel insurance is a must. Fitness for travel also, you should need to find immunization and medication and health summary and medication list. Should have more within the pandemic era. I think that's all my presentation. The last is thank you for the opportunity to join this webinar. Next slide. And I will give the time to the moderator.
Thank you, Prof. Tuti, for great insight about vulnerable travelers. We know many diseases that can make our client vulnerable to travel. And now I will invite all of the speakers, Prof. Swastika, Prof. Pontrap, and also Prof. Tuti, to join this plenary discussion around 10 to 15 minutes. We already have some question on the chat panel, and I see that Prof. was already answered a question in the chat panel, but maybe later we will discuss about it also, Prof. I will read the question. First question is for Prof. Swastika. Is the letter of recommendation for people with diabetes who travels internationally recognized by all airports, Prof? It's the question from Dr. Evi from Perkedwi, Jogja.
Yeah, I think sometime important, maybe in general people with diabetes maybe not need a special traveler letter from the doctor, but in case of the patient bring some equipments like insulin pump, yeah, glucometers, and maybe will be detected by the X-ray examination when entering the custom. I think maybe the traveler letter very important to show to the custom employer, yeah, that I have a diabetes. I have to bring something related to my health. I think maybe will be allowed by the custom employer. I think sometimes very important. Yeah.
Yeah. So we can provide the letter, yeah, for the equipment. Right. Okay. Next question is for Prof. Ponter. Prof, yeah, there's a question from Dr. Indra from Warmadewa University. The question, I once dealt with patients suffering from cutaneous lava migrants, expatriate from Netherlands, live in Bali, who travel to East Nusa Tenggara. If you deal with kids suffering from cutaneous lapa migrans, do you prefer to treat with albendazole or ivermectin, or just let it here on its own in 4 to 8 weeks? Thank you, Prof. Ponter.
For creeping eruption,
Yes.
it can be healed spontaneously in weeks or sometimes months, but it may be longer in those immunocompromised hosts. But it will be at the local. It won't go as the usual route of hookworm to go to the lung migration and go to the intestine. So it's just local and heal spontaneously. So for me, I will give, I don't let it heal spontaneously because some worry of the parents, and I think to give, I give albendazole for 3 to 5 days. So it's kill uh, a shorter time than spontaneously heal. But ivermectin I use in only those immunocompromised hosts because it will be longer, and ivermectin work better in more efficiently, especially in immunocompromised hosts. Okay. Is that I answer your question?
Yeah.
Albendazole for in general, but ivermectin for immunocompromised hosts.
Okay. Yeah, so it's better to treat it with pharmacological treatment, Prof. Yeah,
and I prefer albendazole.
Yeah. Okay. The next question is for Prof. Tuti, and it's also from Dr. Indra. And in relation to Prof. Ponter's presentation, which stated that Thailand has reopened Phuket since July 2021, and Vietnam intends to allow international travel to visit the island of Phuket. Do you think Bali is ready to reopen its border for international travelers this year, Prof? Maybe it's a personal.
Okay, it's a challenging question. Challenging, yeah.
Challenging, Prof.
Yeah, because I will my private opinion, yeah. I will prefer that we do slowly. We do slowly because we know our communication, our population, our community, yeah. There are no discipline, yeah. We learn from the student, which is just get offline in Jakarta for 2 weeks. There is increasing infected teacher, the teacher and the student, yeah, already, and just to be just open it slowly, yeah. We don't say so. In that slowly movement in opening the international travel, I think also because the international countries, so the potential tourists who came to Bali is also still not open their door to Indonesia yet. So this is, I think, an opportunity to us to prepare better, And I've seen a lot of preparation already done by the tourism sectors. Yeah, I think with the villa, with the how to make the event in open air space, and how to deal with the with the in-service, in-room service, yeah, something like that. So in-room or indoor service. So just start to open slowly. I think Dr. Mukti is still in here, so maybe Dr. Mukti can also give add my answer. Yeah, I'm worried if it's just open. Yeah, because work from Bali is already impact Bali in the third. I think can we call the third waves of the COVID-19 pandemic for Bali, yeah. Just when we start the work from Bali, So not so the more people coming is the low level or poor people, so they don't do testing, they don't take the regulation properly, they don't do that. So we found in the hospital that we have patient which is they just come from outside of the island, from come to Bali in 2 or 3 days, and then get infected, serious illness, and admitted to the hospital. That's the report which I know from the resident and our colleagues in the hospital. I think that's my question.
Thank you, Prof. Prof. Pontop, you want to add something to the explanation?
I don't want to touch Bali because I see Levina Pakasi is raising her hand. She will tell you. She will tell you about Bali. But I would like to comment about the school children because Professor Tuti said you see more cases of school children. We also see more cases of school children in Thailand. Now in Thailand it's about 18,000 cases of children. We have more cases of children, but less death in children. Very small proportion of death in children, and most of them are those risk group like obesity, have disease, the medical condition like neurological or chest or lung and liver disease or genetic disorder. So only those high risk children. So, and we found that is the children do not contract the disease in school. They contract in the household. So when you lock them down in the house, they stay more in the house without wearing masks. So they contract the disease from the parents or other people, adult people, and then work from home or online studying is not working because if you have 3 or more children, you have one computer, you cannot share, you see, so very difficult, and they lost their social development, you see. So we now plan to open the school because we know that the school, if we can prevent well, we immunize all the staff, the teacher, the staff, and then we have a new normal, general precaution at school, so it's better than they stay at home. That's the point. So now we on the 1st of October we start to immunize 12 to 18 children, and we plan to open the school in November. So this is the point. Children get the disease in their home. Okay.
Okay. Thank you, Prof. Pontop. Dr. Levina has raised hand. Please, Dr. Levina, you can ask the question directly.
Thank you, Dr. Arya. I just want to make comments, small comments before my questions. Regarding to go to Bali, I think everybody wants to go to Bali now. Whether it is safer than Thailand. I think Indonesia is better now for handling COVID than Thailand. So maybe our president is better than the king of Thailand, I think. But don't worry to go to Bali. But I just want to ask all the speakers regarding these vulnerable travelers, because we are now considering vaccination to go. But on the other hand, we know that the antibody has been reduced largely in the 6 weeks period. So we are now some countries I know has already recommended those of COVID vaccine. So do you still recommend anybody with chronic disease or children after the second dose, or we should manage to go to the third dose? and then it's safer than just to dose after 6 months.
Okay, thank you, Dr. Levina. Maybe Prof. Tuti can answer this question.
Okay, thank you. Hi, Dr. Levina. Long time not see you.
Nice to
Okay.
see you, Prof.
Yeah, nice to see you. About the third dose is, I think for the nakes, for the health provider, they already have the third dose. Yeah, as what the planning from the country, I think they, in principle, the third dose is good, but how can we achieve to the third dose? Yeah, in our country. So they have the priority. Who will be give the third booster in our country? So now there is the health professional, and then the teacher, and then the school student after 12 years. Yeah, and or maybe the public services people, and the mobile people, the very mobile people, because they need that better antibody. Yeah, but for this is what the global issue, that in Africa they don't even get the first dose. So for us with big population, I think if we join the humanity, so don't depend on the third vaccination. I think it's because after vaccination, after the third, we still have to use masker, we still have to hand washing frequently, etc. So I don't rely to the third dose to open the tourism, for example, to open the school, but to practice more on the personal hygiene, hand washing, and wear masks. Yeah. As you see my illustration about the cruise ship, they even now even they have fully vaccinated, but they should use and also use masker and etc. And also they have to be tested before pre-boarding to the ship. So what this means is even you have vaccinated, if you go to close contact, like hotels, like school, like ship, something like that, you still need to be tested even if you asymptomatic, because we don't know who will carry the virus, maybe asymptomatic. Yeah. So I think that's my question, my answer to your question. Very nice question. Maybe another speaker will add the answer. Silakan, Prof.
Prof. Tuti, I have a experience for myself.
Oh, yeah.
I have got COVID-19 after I think around 6 months the second vaccinations, and but fortunately in the mild types, and then we can say no any symptom, no any signs, and then we can daily activity also. Yeah, but I think maybe talking about the third vaccination might be important, but I'm agree with Professor Tuti that since I think so many people not have even one vaccination, one shot vaccination, I think maybe need for spreading first, for more people should be vaccinated first, and then the third vaccination for the vulnerable patients or vulnerable people, I think may be important, like doctor, nurse, and also for in my field is diabetic patient. We know that the diabetic patient is one of the most cause of the severe and mortality related to COVID infection. So I think in the words, the diabetes to be a priority to be get vaccines. Thank you. Yeah.
Okay, thank you for the addition, and I hope the answer will be okay for Dr. Levina. Thank you, Dr.
Maybe or he angry with me. He's still mute. Is Prof Pontep, are you recommending?
I'm sorry, Dr. Levina. Okay,
After second dose, after six months after second dose of vaccine, are we still recommending people with or maybe children to go anywhere for traveling, not for business, for leisure?
So the third dose, you know, it depends on
after the antibodies.
It depends on the country, and it depends on what vaccine you are using. So I cannot recommend because this Thailand situation and Indonesian situation is not the same. You see, it depends on your policy. Because if you see the WHO recommendation, they don't recommendation the third dose because all of the world, many people still do not get the first dose. So it depends. So I keep quiet. You see, cannot comment. Depends on your country.
I mean for all speakers, after six months after second dose, inactivated vaccines, can we recommend anybody to travel after six months after when we know the antibody has been diminished a lot? Can we consider? Can we recommend anybody to travel for leisure, not for business or whatever working, but for holiday?
What you recommend? It depends on the destination.
Okay.
I don't know. It
I don't
depends on
recommend. So anybody wants to go traveling should be in the 6 months period after second dose. Now is the best time for Indonesian to go to Bali. After December, I don't know.
Okay.
Maybe they will increase to 50,000 again a day, but now is the best time to go to Bali before international travelers coming. And we spend 2 months to December. That after December and New Year's, we don't know.
Okay.
So my comment is, Bali is your I think it's up to you. You know the recommendation. If you going internationally, it depends on the destination. Like if you have Sinovac 2 dose, you cannot go to Europe or America because they don't accept it. So it depends on the destination. If you go to Bali, it depends on your country, Bali, whether they accept the 2 dose of Sinovac or not. You see the point? It depends on the destination, regulation. I cannot give the comment. It depends on destination.
Okay.
Okay.
Thank you for Ponta for the. Thank you, Dr. Levina, for the question. It's very interesting question for the all speakers. Unfortunately, our time is end. Yeah, so I will end this session. And I want to say thanks for all the speakers for their informative and interesting talk about the special population in travelers. Thank you all of the audience for the active participation. Hopefully the presentation will be beneficial for everybody. There's one question left in the chat room from Swas. So if you don't mind, please answer the question in the chat panel, Prof. Thank you, Prof. Thank you, Prof. Tuti, Prof. Swas, and Prof. Swastika and Prof. Ponter for the time. I will.
Thank you.
Okay, terima kasih.
Terima kasih, Prof.
Terima kasih, Prof. Pontep.
Yeah.
Regina, Prof. Swas.
See you sometime in Bali.
Yeah.
Okay, I will give the
Ready?
event, the webinar for our host, Dr. Triani. Please, Dr. Triani, continue the session.
Okay, thank you, Dr. Arya, for leading the sixth symposium. And also a big thanks to our distinguished speakers, Prof. Pontep, Prof. Swastika and Prof. Tuti for the very enlightening presentation and also discussions. Thank you also to Dr. Levina who has joined our discussions. So now, before we will continue to the 7th symposium, we will have a 10-minute break. Thank you for your attention.
Sembah bakti kehadapan Sri Kasari Warna Dewa Sabta Bayu Sri Kasari Warna Dewa Pancaran-caran 7 warna terata Inspirasi dalam membangun negeri Membentuk karakter bangsa Untuk wujudkan kesejahteraan bagi semua Sabta Bayu berketuhanan yang Maha Esa Sabta Bayu, ciri kepemimpinan asa brata. Sabta Bayu, mengabdi negeri pada anak untuk bangsa dan negara. Sri Kasari Warma Dewa
Sabta Bayu Spirit Sri Kasari Warma Dewa Pancaran 7 warna terata Inspirasi dalam membangun negeri
membentuk karakter bangsa untuk wujudkan kesejahteraan bagi semua. Sabta Bayu dalam berkarya. Sabta Bayu integritas diri. Sabta Bayu mengawal kebinekaan dalam masyarakat untuk wujudkan persatuan. Sabta Bayu berwawasan trihita karana untuk wujudkan kesejahteraan bersama untuk kejayaan Indonesia Raya. Sabta Bayu. Berkibarlah bendera negeriku, berkibarlah engkau di dadaku, tunjukkanlah kepada dunia semangatmu yang panas membara. Daku ingin jiwa raga ini selaraskan keanggunan. Daku ingin jemariku ini menuliskan karismamu. Berkibarlah bendera negeriku, berkibar di luas nuansamu, tunjukkanlah kepada dunia ramah tamah budi bahasamu. Daku ingin kapal tangan ini menunaikan kewajiban putra bangsa yang mengemban cita hidup dalam kesatuan. Daku ingin jiwa raga ini selaraskan keanggunan. Daku ingin jemariku ini menuliskan karismamu. Daku ingin kapal tangan ini menunaikan kewajiban putra bangsa yang mengemban cita hidup dalam kesatuan Indonesia.
Good afternoon from us in Bali. So thank you for all participants who are still attending this webinar. So we will continue to the last symposium of the WIWTM 2021. The last symposium will be about cocktail nibbles. But before we start with the presentation from our key speakers, I would like to introduce our moderator today, Niwayan Erli Cynthia Dewi PGDIP MSI. Her academic background is graduated from Gajah Mada University as a Bachelor in Science in Biology in 2008. She is also graduated from King's College London in UK in 2017 for postgraduate diploma in medical imaging. She was also graduated for MSc, the Master of Science in Biotechnology from Bandung Institute Technology in West Java in 2021. Her current position is lecturer at the Department of Physiology and Biochemistry in the Faculty of Medicine and Health Sciences, Swarmadewa University, Denpasar, Bali. Her awards and research experiences were researcher at Chemical Engineering Abo Academy University in Finland in 2015 to 2016, internship in the School of Engineering in the University of Edinburgh, UK in 2017, research collaborations with Queensland Institute of Medical Research and Ekman Institute from 2018 to 2019, one of the best oral presenters on the 4th International Conference on Pharmacy and Pharmaceutical Science, ICPPS 2019 in Meiji University, Tokyo, Japan in 2019, and research collaboration with London School of Hygiene and Tropical Medicine in 2020. So, Ellie, the time is yours.
Okay, good afternoon, everyone. Good afternoon from Bali. So thank you very much for Dr. Triani for the nice introduction about myself. So today for the last symposium, I will be the moderator for this symposium. And let me share screen first. Okay. Sorry, there's a technical problem. I will start share again. So can you hear me clearly, Dr. Triani?
Yes, Ellie.
Okay.
I can hear your voice clearly.
Okay, thank you. So yes, so for the last symposium, the title for the last symposium is Cocktainables related to medical travel medicine. So here we will have two inspiring speakers, which are Dr. Adi Wirawan Eskat, MPH, PhD, and also Madam Santi Samdasani. Before I invited our first speakers, I would like to read his CV first. So Dr. Adi was graduated as a medical doctor from Faculty of Medicine Udayana University Bali 2001, and he got his Master of Public Health from Monash University Australia, and then he got a Doctor of Philosophy from University of Otago, Wellington, New Zealand at 2015. So he's currently a Vice Dean at Faculty of Medicine Udayana University Bali, Indonesia. She's also Associate Professor at the Department of Public Health and Preventive Medicine, Faculty of Medicine Udayana University. And he is a Program Coordinator for a Bachelor of Public Health Udayana University. His job experiences was a Clinical Research Associate at Medoc Research US Norway for clinical trial monitoring in Indonesia and Thailand, General Practitioner and Travel Medicine Practitioner at Medical Traffic Bali, Indonesia, and also a faculty member at the Department of Public Health and Preventive Medicine, Faculty of Medicine Udayana University Bali, Indonesia. He has many publications related to public health, and his latest publication is a geomapping of hazard, risks, and travel health services in Bali, result from the first stage of the integrated travel health surveillance and information system at the destination project. So it already published in Travel Medicine and Infectious Disease 2020. So I think everyone already excited about Dr. Adi presentation. So Dr. Adi, the time is yours.
Thank you very much, Early.
Yes,
Early. Early, thank you for the nice introduction. Good afternoon, everybody. So I would like to present a travel health surveillance, the opportunities and challenges. So I'll try to share my presentation first. Yeah. So can you see early?
Yes, clearly, doctor.
Yeah. So on these presentations, I would like to highlight some of the epidemiological aspects of the travel medicine. So we will talk a lot about the why travelers are very important populations in terms of the epidemiological perspectives, and how we at destinations can deal with that. So because so far the travel health surveillance still focus on the country of origins perspective. So we at destination still lag behind on this. So I'll try to present a little bit of concepts on the travel health surveillance and a little bit experience what we had done in Bali as one of the tourist destinations. So as I mentioned earlier, that the travelers themselves are a very important population because they have a high mobility. So they can move from one place to another very quickly. So they also spread the disease very quickly. So the COVID-19 pandemic is one of the clear example how the pandemic is as how the rules of travelers during the pandemic. And the travelers themselves are more susceptible to diseases compared to local population or the host populations, and risk of importing and exporting diseases, so bringing disease to the country of origin or bringing back to their own country. And the last consideration is because travelers are heterogeneous groups. So each subgroup has different risks. So a lot of publications, scientific publication on this already on how a different subgroup has different risks. So this graph represents the proportion of travelers based on their purpose. The majority of them are traveling for pleasure, for tourism, so more than 60%. And other purposes can be simplified as this. The blue one belongs to the visiting friends and relatives, or for health and religion purposes, like pilgrimage and so forth. And the orange one is for business and professional. So our concern here for the blue portions, because some scientific literature suggested that those visiting friends and relatives are more susceptible to travel-related diseases, especially those with fever symptoms, like dengue, malaria, or other tropical diseases with fever symptoms. And those with main aim to do their business or professional group is considered to be the most what do you say, the most aware of the risk at destination. So they have the highest percentage of doing pre-travel counseling, pre-travel vaccinations, and other pre-travel services at their country of origins. And those with the main purpose for pleasure or for tourism, they are more prone to travel-related accidents because they engage a lot with the travel-related activities. So different subgroup actually has already different risks if we see them from the epidemiological perspectives. So what are the challenges in providing data on travel epidemiology? So the first one, because we have a limited knowledge on risk of diseases for specific regions. Even in Indonesia, as we know, Indonesia, thousands islands, and from west to east, the risk of diseases for each province, for example, maybe we as a medical practitioner not really we know in general, but not precisely, like in which area is the falciparum malaria, for example, dominant, or what is dominant in the Komodo Islands, and what is the consequences for giving like a chemical prophylaxis for travelers who want to travel there, and what are the risks in the Sulawesi Island or in Kalimantan. It's only in Indonesia we already get difficulties in remembering all of those region specific risk. And if we talk globally, and the diseases are more a lot more that we haven't met yet the cases, like yellow fever, like other diseases in the sub-Saharan Africa, for example, or in Latin America. So a lot of diseases where it's very familiar for the medical practitioner at destination, but we in other part of the world probably need to know them if we want to provide a comprehensive pre-travel services to travelers who want to go there, for example. So number one, it's not only our problem, but I think this is a problem for all of the travel medicine practitioners all over the world. So that's why some company provide services like the TravX, the Shoreline TravX. They provide a list of disease risks or a list of hazard, specific hazard at some destination, for example. And the second challenge is difficulty in measuring risk. So we don't have a good estimations of what are the incidence rates or the prevalence rates of the specific travel-related cases or travel-related accidents, because we cannot count exactly the numerical data, how many travelers with certain diseases or cases, and how many of them are at risk. So the total number of travelers at risk. This also challenges in all over the world. So providing data on travel epidemiology is really hard in terms of absolute or relative risk. And also it's related to the incubation period of diseases as well. So travelers infected with a disease has gone back to their origin when signs and symptoms appear. So this will create problems at the destination, so surveillance problem at destination. This is particularly for diseases with long incubation period. Fake fasciolosis, for example. A lot of fasciolosis that caused by Fasciola hepatica reported in Australia. So returning travelers from Bali, for example, in Australia, they are diagnosed with fasciolosis there. We don't have any data here how many travelers got infected here, so we don't have any idea what should be done here because we don't have the epidemiological data. And likewise, with diseases with short incubation period, so usually already cured, already completed or resolved at the destination, and it create problems, surveillance problems at the origin. So those country sending the travelers don't have what kind of diseases that their travelers got at destination. And also problems with misdiagnosis. Mild diseases tend to be not reported or reported with inaccurate diagnosis. And again, a traveler visit many places, so they very have high mobility, so difficulty in determining infection site or locations. Like if they got malaria in Indonesia and they just come from diving sites all over the world, or sorry, for in Indonesia, for example, like diving sites in Bali, and then they go to Raja Ampat or Wakatobi, because within those incubation period is when the symptoms occur, then we have to determine where is the infection site or location to provide a valid epidemiological data. So what are the most relevant surveillance data so far? So because of the high mobility, it is highly suggested that using surveillance on the travelers themselves. So we track the travelers, and those strategies already implemented by International Society of Travel Medicine, ISTM, with the CDC. they create what is called as the Geosentinel Surveillance Network, or Geosentinel. Probably most of us already heard about this. And a similar surveillance network in Europe, they call TropNet in Europe. So it's a European network for tropical medicine and travel health. And in Canada, they have a TropNet. So it's also part of the ISTM networking. And in the US, they also have the G10, Global Travel Net, involving travel clinics, primary care, and public health sites. So those network surveillance network aim at providing surveillance epidemiological data for the CDC of each member of the member of the member country to provide preventive measures if the data shows there's a lot of cases come to their country, a lot of new parasitic infections acquired by the travelers, for instance. That's the main purpose. So basically, they want to stop the importations of diseases from the tropical countries. So if you go to one of the US travel clinics, for instance, they will provide nearly all of the screening tools, all of the swabs tools for detecting the parasitic infections to prevent such diseases, bringing in by the travelers when they going back from the Africa or other Southeast Asian countries or in tropical countries. So these networks are all in the developed nations in the perspective of the country who send their travelers to destination, but we don't have such system at destinations in Bali or Indonesia. That's the main problems that we have here. So looking back at what kind of surveillance system they have, the GeoSentinel, EuroTrapNet, CanTrapNet, G10s. So basically, they have input for the data collection from the outreach patients and travel clinic patients, and aggregate all the data into a database. And the database will create the clinical alerts and also providing regular summaries. And this data will be used by the network to provide feedback and to create the epidemiological data and publish it in scientific literature to give an estimations of the risk of a specific disease in a specific country and how to prevent them or provide more suitable preventive measures to the travelers. It's very simple actually, but needs a lot of effort for the creating the networks, I think. So these are participating sites for the GeoSentinel. We can see that here no participating site in Indonesia, unfortunately. There's some participating sites in Southeast Asia, in Thailand, in Malaysia, and in Singapore, but none of them in Indonesia. So we didn't contribute to the GeoSentinel data. In 2019, actually, Professor Davidson Hammer, the principal investigator for the GeoSentinel, when he came to Bali, so he very kind to put Udayana University Hospital Travel Clinic as the GeoSentinel affiliate member. So he's not a full member yet, with obligation to report regularly. So GeoSentinel affiliate member means that we got access to the groups, to the network, and follow what the conversations there, and we can report any cases which is like special cases or any diseases that potentially become the potential to be a pandemic for the next pandemic, so emerging diseases. So we can report to the GeoSentinel with the status as the GeoSentinel affiliate member. But so far we need a GeoSentinel, a real GeoSentinel site actually, we can contribute more to the broader community. So what are the limitations of this geosentinel data? Can we use their publication for policy in Indonesia or at destinations in general? So the geosentinel and the likes, like HandTrapNet or G10s, they use a companion sampling. They use ill-written travelers. So when the travelers come back to their country and got sick, and they go to the participating sites, and they will be recorded in the geosentinel database. So basically, they are not representatives of all traveler population. So if we come back to the concepts of the role of incubation period, the short and long incubation period, so probably the more catches the diseases with long incubation period, because it's ill-written travelers means that when they got infected, and it at least 1 week for the symptoms to appear on them. And the second problem is the differences in population and travel destination between sites or clinics. So still there is difficulty in determining the denominator. So the absolute and relative risks are still difficult to calculate. And again, the no participating site Indonesia means that there are lack of information on symptom respective diseases that could potentially be employed to improve surveillance system and public health in general. Because Indonesia itself has a variety of diseases that other countries don't have, for example. So we have all types of malaria probably, and also the dengue fever, Japanese encephalitis, and rabies, and other infectious diseases that needs to be incorporated into the geosentinel data. So what the local surveillance system do? So in Indonesia or in Bali, especially because we have contacted some of the surveillance officers. So the surveillance system in Bali or Indonesia in general has focused only on the diseases affecting the local population, because that's already a big burden in the running this surveillance for our own disease. So the result is the lack of robust and integrated system that involve travelers. So they don't have a specific data on travelers. Probably some clinics, they have they spread the data, but it's not managed well by the local authorities yet. So we don't have, or little has been known about the common diseases or symptom experienced by travelers in Indonesia. So even we don't know what is the proportion of or the prevalence of traveler diarrhea, for example, in Bali. We cannot provide the accurate data, or what are the prevalence or the incidence of the dengue fever among the travelers. Because of the local surveillance system not creating an integrated system is still occupied by the local problems with the local diseases. And also the current surveillance system has not included travelers. It's one of the target population, not in their main indicator, performance indicator. So it really depends on the reporting by the health facilities or health providers who provide services to tourists. So if they provide their report regularly, maybe it's an opportunity for the health office or the district health office or provincial health office to gather the data and to analyze the data. So there is no regular travel health surveillance currently in place officially, and one of the efforts related to this is the sporadic investigation if there is cases of specific diseases among travelers. Yeah. So they will conduct like contact tracings containing the cases and the epidemiological and surveillance for that specific cases only if there is a case in Bali. So it is a little bit experience in developing the travel health surveillance at destinations. So we have a conceptual framework for the travel health surveillance at destinations. I can share here based on our research conducted by our research group at Udayana. So
Dr. Adi,
yes.
sorry for interrupting. We still have 2 minutes for your presentation.
Okay, thank you for the reminder. So we have this framework for improving the travel health surveillance in Bali, and currently we already in this phase to create the travel health provider network to make the health facilities are accessible for travelers. So we have finished the first one to provide the digital surveillance as the feeder for the next system, and we try to incorporate all the aspects of developing the travel health surveillance in the digital era provided by WHO to make the system is more comprehensively can be accessed by travelers, so the travelers can visit this the information system, and then they will connect it to travel health provider, and the travel health provider have a network among themselves. So there will be a digital tracking and decision support, including the provision of educational and training, stock notification, and so forth. So this still in the development phase. And so what been done in the first year, we map all of the travel health facilities providing services to tourism in Bali. So it's around 197, I think. I think it's in 2019. So I think now it's more travel health providers or regions because of the pandemic situations. And we also perform the risk analysis at tourism areas, categorize them as low risk, medium risk, high risk, which each specific hazards, specific diseases that potentially be a hazard to the travelers. And this is the first phase to provide information, travel health information to tourists with Bali Travel Health websites. And from this website, we also analyze the trends of the keywords of the pages that they access. So we use it as digital surveillance to support the actual surveillance system. And this in this year project, so we have collaboration with the Harvard School of Medicine to provide the this Bali Travel Health Network. So if Canada have ContrapNet, EuroTrapNet, so we will have a Bali TrapNet soon. And if this successful, we will expand it to all Indonesia to become the Indonesia Travel Health Network or IndoTrapNet. So these are the challenges that we have in the pandemic situations, that we cannot actually run the projects according to the timeline. So from what we have done so far to strengthen the surveillance system among the travelers and to provide a travel diseases data more accurately at destinations, we need to integrate all of the possibilities. The integrated approach is must, so we can provide the travel information. So what is called as a targeted travel communication based on specific hazard and risk. So this will also create what we call as the digital surveillance. Yeah, this new concept in surveillance that we want to involve in this travel disease surveillance. And at the same time, we have to create or to build a travel health network among the travel health provider. So improve accessibility, stock notifications, community management, and also we plan to include also the provision of training among the travel medicine practitioners, and providing education material, and also digital tracking and decision support, which eventually provide high quality travel health services at destinations. So those presentations or slides, I think will give a little bit of a view of what happened actually with the surveillance data of the travelers of travel being sick, how how your data can be beneficial for public health in general. So not only for the travelers' health, but also for the public health at destinations. That's the main goal, so the main aim of the healthy tourism initiatives that we already started a couple of years ago, and we hope this concept can run in a couple of years and provide contributions to the global community to support or fill the gap in the travel medicine, Sentinels data, for example. I think this is my last slide. So thank you very much. That's all for today. I'll hand it back to the moderator. Thanks, Erli.
Thank you, Dr. Adi. It's a really nice presentation, and it's a thoughtful presentation as well. I think we still have like quite many issues related to travel health surveillance in order to get it become better. So now I would like to introduce our second speakers for this symposium today. Okay. So for the next speakers, we have Madam Santi Samdasani. So her academic background was she's graduated as an executive education digital transformation from Harvard Kennedy School, USA, and she got a Master of Business Administration from Venus University. And she's currently doing her PhD in law in UPH University. She's currently a president at Asian International Advocacy and Consultancy. She's also a board member of East Asia Business Council and a chairwoman at Asian India Business Council. She is a vice chair from KADIN, or Indonesian Chambers of Commerce and Industry. And she's also a chairwoman at Healthcare, Biotech, Pharmaceutical, and Devices. So her job experiences was 20 years in healthcare, including pharmaceutical, medical devices, and also OTC products. And for the second, founder and CEO of Sanaika Med Consult, and she's also a founder of Med Consult Asia. She has a lot of experience as a speaker and also expert panels. So the latest one, she was one of the lead speaker with 3 ministers in Indonesia in the topic of the tomorrow of COVID-19 vaccines. So before further ado, Madam Santi Samdasani, the time is yours.
Thank you very much, Erli. Good afternoon, everyone. My pleasure and honor to be here today. What I'd like to do is to try to share different perspectives of, I think in the last 2 days, I've observed that the discussion has been very much around epidemiology and discussions around the scientific aspect and the data collection. But what I would like to show here, and let me just share my screen a little bit. Okay. Can you see my screen?
Yes, clearly.
Okay, let me just enlarge it so it can be seen. Okay, so what I'd like to focus on is what we have been working on, and just to give you a bit of a background. The ASEAN International Advocacy is a consulting firm which provides full-fledged consultancy for healthcare around Southeast Asia. So we have offices in Philippines, Singapore, Dubai, India, Malaysia, and Laos. And the same thing with the Med Consult Asia and also with Sanaika Med Consult. So we are actually one of the leading telemedicine consultation with over 25 doctors and hospitals internationally, as well as we promote Indonesian doctors into international area for consultation. So we have a lot of our Indonesian doctors who are consulting patients from Laos, from Cambodia, and also from from Myanmar. I want to just go briefly over what happened during pandemic. And we know that during the pandemic time, digital or the uses of digital or the uses of virtual or technology has been sped up. Before we were talking about technology for a long time, but the uses of technology and the adoption of technology was a little bit slow. But I think what the COVID-19 pandemic has done is it has expedited all of us, not just one or two segments, but the whole world to really and force themselves to learn about the use of technology in every aspect of their life. So I'm not just talking about online shopping and just about social media, but even in healthcare, we have seen there are more and more patients who are fearful of going to the hospitals because of the pandemic, and who once, because of convenience, they wanted to have a more of a convenient way of getting the same quality of services of healthcare as it relates to when they go and visit the doctor physically. So telemedicine is something which has been an ongoing thing since the last 5-6 years. And I think this will be the future as well. But what are the challenges of telemedicine? And this is where I would like to speak today to all of you, really. I mean, we all know the benefits. We all have seen how HelloDoc and a few other apps in Indonesia and worldwide has actually helped telemedicines, and even hospitals now have their own telemedicine departments and divisions. But look at the slide here. We have the telemedicine. We have, of course, the community residents, which is even psychological consulting is being conducted online now, so you don't have to have a face-to-face consultation with your psychologist. But we have the medical staff and we have the patients. And this is the interesting part here. When it comes to the medical staff, there's a lot of training that needs to be conducted. And this is what I've observed in Indonesia compared to Thailand and Singapore, for example. The training to provide quality improvement, panel discussion, psychological discussion, dialogues, because I think our doctors are still not used to looking at patient through their laptop and telling what is wrong with the patients. I think that in the same way, we are not used to working from home from in the beginning, right? But now we are so much used to working from home. If you tell me to go to the office, I may not want to go to the office every day. So the same thing, what I've seen happening is the doctors are in the beginning was a little bit hesitant in diagnosing a patient just by looking at the patient through their laptop. But there are technologies now, there are artificial intelligence, AI now that has been brought into the application, which we have, where you can see how many times a patient blinks, what is the face, whether the patient is in pain or not, how is the sound quality, what are the leaning positions, and the facial muscles and all those things. The technology now can help take up all this information and provide it to the doctor in terms of giving how much of a stress level the patient is under, and that which will help doctor to provide further diagnosis. So looking at this one, we see there are a lot of training and a lot of catching up that we need to do in terms of how do we address a patient virtually. If you look at the global adaptation of online health, or you want to call it virtual health, telemedicine, there's so many names to this, right? In Indonesia, everybody knows as telemedicine. But if you look at this one, I think there are these 5 the elements of telemedicine. First is the medical education, which all of us, I think, what I've seen from the panel of speakers here, very well dignified and very well elaborated experience that an international and also local experience of speakers, which we have, which is really great. But the question that everybody have is that how can you bring your years of experience into this setting? This is a new setting, right? And then you have the medical education is, of course, a total must, right? And then the telemedicine, but then you have the electronic medical records as well. You have the patient solution system, which is, again, I think it's a whole separate presentation, but the patient solution system, like what I think Dr. Addy, my previous speaker, talking about data epidemiology itself, it's very challenging for us to even collect a simple data, right? And without having a simple data, as you know, artificial intelligence now work on data, right? The more you feed the system, the smarter it becomes, right? Now, if you don't have enough data, how can you feed the system? It's like Indonesia doesn't have enough food to feed the artificial intelligence system, so it can become smarter quickly, right? There are other countries who have a lot of data that they kept feeding on the AI, the artificial intelligence, and hence international other countries are more advanced in terms of telemedicine than we are because of our lack of data collection. Then there's medical diagnostics, which is one of the tricky one. And we in Shanaika Med Consult, we have patients with cancer, liver cirrhosis, kidney failures, and heart disease. So we need to be very, very careful in terms of how we use technology to help these patients, right? And to help the doctors as well, right? And this is just the example of Singapore. And then you have a separate division, which is health management solutions. Now, it starts from the medical education into telemedicine, electronic medical records, and you get the patient solution, and then the medical diagnostic solutions, and then the health management, and lastly, the personal health and fitness. Now, in terms of personal health and fitness, you see a lot of in the area of wearables, where people wear the thing in their watch, a replacement of their watch and all those things. But this is what we see happening, and this is in Singapore, right? Some of this are happening in Indonesia, but at a kind of like, not at the same pace as Singapore, but at a different stages. Now, if you look at the adaptation here, the same thing again in South Korea, right? So previously, this was Singapore, and then you look at South Korea. The pace is more or less the same, and we haven't had the data yet for Indonesia, right? But if you look at this one, the elements are the same. There needs to be a medical education, telemedicine, the electronic media records, patient solution, diagnostics, monitoring, and then personal health and fitness regimes, which is a sustainable. You're actually able to sustain a patient's health through adopting technology into the whole medical and doctor-patient relationship system, because there's only so much a doctor can do. So the technology can help the patients quite a lot. If you look at the trends, these are the emerging trends, and I've circled the one in red. Remote patient monitoring is one, which is, if you talk about technology, right? I mean, precision medicine has been something which we have heard the last 10 years. Last 10 years, people are focused on precision medicine. But I think after the technology the technology has come in, and people are more and more focused on how to make things more effective and more efficient. Remote patient monitoring is one which is really high on the list, right? And then you have virtual clinical trials as well. And this is interesting because in my company, we do clinical trials, not just in Indonesia, but in Philippines and in India as well. So now we have what we call is a virtual clinical trials. And this is something which is going to be more and more common in the future. And then, of course, electronic health records. Everybody has been talking about it. Like, how do we put our health records, store it in a cloud or in an electronic system? If we are able to do this, then what Dr. Adi was presenting earlier, where we have challenges on data, epidemiologies, and all those things, that could easily be overcome. We will know how many tourists in Bali have diarrhea after eating sambal, for example, or after being in Indonesia or in Bali for a couple of days, because there's change of food, right? If I travel to Germany or I travel to US, I would have a stomach upset because my stomach is an Indonesian stomach. I'm used to eating spicy food. In the US, I just eat very raw kind of like food, right? So there is that kind of thing. And then they have the data in the US quite quite well managed. But I think this is one area where we can use technology to really store the data on tourists and not just tourists, but patients basically, and their symptoms and the disease areas, and we segregate that between the travelers and the locals, right? But this is the trend that you see in technology healthcare, and I think this is my last slide. So I would just want to discuss on the challenges. Again, I don't want to touch on the benefits and all that. Everybody knows about it. But the challenges in to adopting telemedicine, the first thing is reimbursement issues. A lot of us have what we call insurance, right? Asuransi. So if I go to the hospital, I take out my card, my insurance will pay for everything, and I just sign and leave the hospital. In a telemedicine, that is still a question mark, right? We still don't know what the reimbursement system would look like. Lack of awareness from the physicians. Again, I mean, there is the physician side is the challenge, not so much the patient side, right? The patients are okay to call or to do a Zoom call with the doctor, but sometimes it's the doctors that are also hesitant to do that. The technology requirements, internet, smartphones. I mean, sometimes you're doing a teleconsultation and then your internet connection is not very good, right? And that also creates a little bit of a challenge, especially Indonesia, where some parts the technology is not, it's not there yet. So, and then the desire to see physician face to face. We still see a lot of our patients have the desire to go to the doctor, to talk to the doctor face to face. They have this comfort in doing that, and having the doctor to physically examine them. Right. Another biggest challenge which I see we will be having in the next 5 years at least, and it's legal and regulatory environment. What are the regulations for telemedicine in Indonesia? It's still not very clear. But we see a lot of companies which have already started practicing telemedicine, right? But the regulations and regulatory environment is still not very clear. Despite that, hospitals are just going ahead with telemedicines because they have to make sure that they are staying connected with their patients, right? So I think this is one of the biggest challenge. And then the lack of awareness from patients as well. See, for us to adopt to change, for middle to upper class, people, to adopt to change is pretty easy because we are more agile than the middle to lower class, right? For them, it's like if I have an illness, I have to go to the puskesmas or I have to go to the near hospital to see my doctor and get some medication or get an injection, and then I will feel better, and then I'll go back home. There's a psychological impact to that, right? Now, there is not such a big psychological impact if you're ill and then you open your laptop or you open your handphone and you talk to your doctor. After that, you may not still feel better because you don't get your injection through the phone and you don't get your medicine through the phone, right? You just spoke with the doctor. So there's that kind of like psychological quote unquote, what do you call it, implications to the telemedicine as well. Regardless of all these things, I think telemedicine is here to stay. We have Shanaika Med Consult have started in late 2020, and we are growing significantly as well. And we are not just having Indonesian patients consult with international doctors, but we are also having Indonesian doctors. We are also promoting Indonesian doctors to consult with international patients. So it kind of like goes both ways. So I think I'll stop here, Ibu Erli, and then I'm open to questions if there are any. Thank you.
All right, thank you so much, Madam Santi. It's really nice presentation, information as well, how we can use technology like artificial intelligence to work with our patient, or maybe we just how to increase the health system in Indonesia. So it's very nice presentation. Thank you. Okay, for everyone, so if there's any question for Dr. Adi and also Madam Santi, you can raise your hand or you can ask directly to them, or maybe you can also write down your question in chat room. So here we have one question to Dr. Adi from Madam Santi. Why did we not participate at Geo Sentinel, Doctor? Maybe you can answer the question first.
Yeah, it's a good question, Mbak Santi. Mbak Santi. Yeah, why did we not participate? Yeah, actually there's quite simple step to be a Geo Sentinel member, but the requirement to be recognized as a travel clinic, which has a minimum standard for the for handling the Geo Sentinel patients. That's we're still working to that standard. So not all of the clinics in Bali, for instance, they have physicians or doctors with certificate in travel health, for example. They have recognitions with travel medicine certificates, and also standard for the clinic management. Because we will feel like a simple form, but that contains like informations on what we provide in the clinics and how many patients we see each month, and how many of them are travelers. So what is the estimated number of travelers that we will see, and how the information system of that clinic, whether it's eligible for the involvement in the Geo Sentinel. So I said it's simple, but the policy from the like the clinic managers or hospital managers or the governments in general, they still not see it as the didn't see it as the priority. That's the problem. So if the policy is supporting those efforts, I think it's not difficult, I think, to fulfill the requirements.
Okay, Dr. Adi, thank you for the explanation. Maybe I have a question following Madam Santi question before. So basically, I think you already heard that Bali planning to open border for the like international flight with this condition, like this COVID-19 condition. So what do you think about the travel surveillance that we have in Bali? So is that ready for that condition, or do we need still more improvement to protect like our health system in Bali? Thank you.
Yeah, thank you, Erly. So reopening tourism is always a difficult question to answer. We have seen in the middle of the pandemic last year, in the middle of the year last year, some countries tried to reopen the borders, and the cases are starting to increase again. And with a lot of variants, and also the risk is still there, especially in Bali, because we still have some cases ongoing here. The surveillance systems, I think, for contact tracings and also for the containing the cases and isolation, quarantine, I think the governments now is ready than before. Yeah, before pandemic, we never done such post-travel services. So in travel medicine, we call it post-travel services. So all the travelers coming in, we do a screening test for to exclude them whether they have COVID-19 or not, and followed by the isolation or quarantine. So that's type of post-travel services never happened before, and now during the pandemic, we think that's a good sign of the improvement in surveillance system. And how we track the travelers when they come to Bali and they release to the destinations, that's still not clear to me at the moment. But the preparation now is in the three area, like in Nusa Dua, Sanur, and Ubud for the preparations. They call it as a priority area for the reopening tourism. That's only include the usual testing, the tracing, and isolating as per current protocol. But the digital systems, it's not. I'm not sure how they can track and how they can monitor the movement of the travelers yet. Probably there will be more preparation on that, because the pressure from the industry, the tourism industry, is quite big as well. The pressure is very high to open tourism because the economic reasons, and we already fatigued with the situations, and we can understand that's a policy. And I think we will see the policy in a couple of months, whether we'll reopen or not. And the current system, we hope they can enough to handle the situations.
All right. Thank you, Dr. Eri, for the nice explanation. So here in chat room, we have several questions for Ms. Hanti. So the first question is from Dr. Komang Triani. What is your opinion on the challenge of practicing telemedicine in Indonesia? And another question is from Dr. Indra. How do you think we're supposed to charge our patient fairly for telemedicine consultation? Maybe Ms. Hanti, you can answer the questions.
Thank you for that. I think the challenge for telemedicine in Indonesia is still the lack of awareness between patients and doctor. It started with a telemedicine from the middle to up community, but those with laptops and those with set doctors either in Singapore or set doctors in other hospitals, right? But for middle to low, for people to consult their doctors through handphone, like just holding the handphone like that and talking to the doctor, is still requires practice and requires a big amount of awareness. People go to HelloDoc, but they don't do, most of them don't do face-to-face. They just kind of like type what their problem is, right? It's just still typing. And, like sakit perut or mual. And then there is a doctor on the other side, which will also be typing, chatting, right? And then we'll be asking questions. That is okay for a minor disease areas, but for more serious disease areas like our patients at Shanaika Med Consult, where our patients are mostly having chronic diseases, you can't just chat. You need to have a separate setting, and you need to sit down with a clear system. So I think the challenge here would be more of an awareness, both from the doctor's side and the patient side. I think we need to start talking more and more about this. Even the doctors need to start talking, because sometimes what happens is, I can see from the doctor's side, doctors are not talking about it because the doctors community might feel that, oh, number one, there is no regulation to support telemedicine yet. So if I talk to my patient about telemedicine, am I making a crime? Am I going against the law? That's number one. Number two, I see sometimes even ED, Ikatan Dokter Indonesia, are not very supportive of the telemedicine, right? So I think if it starts from ED and they support the system, then maybe their doctors could tell their patient, you don't have to spend 3 hours in traffic to come and see me. You can just make an appointment through Zoom and we can chat over the Zoom. Unless you are, you are in a severe pain and I need to inject you and all those things. But if it's just for a consultation, you can do it. I think it requires more awareness and education. So that is the first question. And the second question is how you're supposed to charge your patient fairly. I think in order to charge the patients fairly is that, in my case, in the case of Shanaika Med Consult, is that you charge the patient according to how you would charge your normal patient per hour, right? Or per visit, right? So this is how we tell the doctors, because the doctor's role didn't change. right? The doctor is still giving his time, whether it's 10 minutes, 15 minutes, half an hour, to the patient. So I think you need to charge your fees based on your hourly rate or based on your services. If you're looking at a patient, if the patient comes face to face to you, you are charging 450,000 rupiah for one consultation. Then online, maybe you can make it 400 or 350,000. There's still a lower amount of fee associated with it because you are not putting so much time as you would if your patient was in front of you, right? So it's slightly lower, but not higher. If not the same, maybe slightly lower. That's how I would advise my doctors to do it.
Thank you, Madam Santi, for the nice explanation for the questions. And the last question for Dr. Adi from Dr. Arya. What is the future plan for Bali travel, Doctor?
Yeah, we are currently in developing the network among the health providers. So it's a pilot project. So only selected travel clinic will be included. And if that successfully proves that the system can be used, and now we plan to use the influenza like illness surveillance during the pandemic. So all of the domestic and international travelers, because we don't have any international travelers yet, so we rely on the domestic travelers, and all patients see by the doctors at the travel clinic, and how it's going with the surveillance system. And then we will recruit more and more. So all of the clinic or travel clinics in Bali who provide services to travelers will be included in the network. So they will have it will provide benefit for them because they will be promoted through the website as well. And we also can get the data from their reporting regularly. Yeah.
Okay, continuing Dr. Adi question. So is there any possibility for other institution maybe to join the network, Doctor? It's like
yeah, sure.
maybe.
So yeah, we will collaborate as many as possible with other institutions. Yeah, more people is the better.
All right. Okay.
Yeah.
Thank you, Dr. Adi and Madam Santi, for the nice presentation discussion this afternoon. And I would like to give it back to our Master of Ceremonies, Dr. Komang Triani. Thank you.
Thank you.
Thank you, Ellie. Thank you,
Thank you.
Bu Santi.
Okay,
Thank you, Doctor. Thank you.
Yeah. Thank you to Erly for leading this last symposium for this webinar. Big thanks also to our wonderful speakers, Dr. Adi Wirawan and Miss Santi Samdasani, with your wonderful presentation and also very exciting discussions. So this is mark the end of our webinar. But before we close our webinar today, I would like to invite Dr. Made Indra Wijaya, Mars PhD, to close this webinar. Dr. Indra, the time is yours.
Thank you so much. By chanting Om Dewa Suksma Parama Achintirya Nama Swaha, as the chairman of organizing committee, on behalf of the Dean of the Faculty of Medicine and Health Sciences, University of Warmadewa, I officially close this webinar. Thank you so much for all participants and all members of the organizing committee, as well as for the invited speakers. See you next time in our future webinar. Om Santi, 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 Om.
Thank you, everyone.